principles in pharmacology. We're going to do pharmacokinetics and pharmacodynamics, enzyme kinetics, uh, Michaelis-Menten kinetics. That is, Km is inversely related to the affinity of the enzyme for its substrate. Okay, so and Vmax is directionally proportional to the enzyme concentration. The more enzymes you have, the more Vmax you have, and this is inversely related to the affinity of the enzyme to its substrate. So if the enzyme is attracted to the substrate more, then Km value is going to be less. And if the affinity is less, then Km value will be more, right? So most enzymatic reactions follow a hyperbolic curve, that is Michaelis-Menten kinetics. However, enzymatic reactions that exhibit a sigmoid curve usually indicate cooperative kinetics. For example, hemoglobin. Here we have substrate right there and concentration of substrate. Um, so that's concentration of substrate, and then we have velocity for V. Okay, so we have Vmax here. That's the enzyme concentration, right? And this is half Vmax right here and Km value. Effects of enzyme inhibition. So Vmax saturation is right here, and half Vmax is here, Km. Okay, so this is non-competitive inhibitor. Notice how the concentration is less, but it's achieving steady state much faster compared to the one where it's saturated. And competitive inhibitor reversible is this green line over here. Okay, so what does this all mean? I try to make it easier for myself by making notes on it. So in competitive inhibitor, you have the same Km value, but the higher, uh, same Vmax and higher Km value, right? So here the Km value is the one that will change. So let's take that here and see if it makes sense. Let me put it there. So normally this is the one that they ask you to, they don't ask you, but this is what you should know for the basis. So, but what they're going to give you is like a straight line like this, right? And then it's much easier to understand. So let's do this. Lineweaver-Brook plot. The closer to 0 on the y-axis, the higher the Vmax. Okay. Closer to 0 on the y-axis, the higher the Vmax. Okay. The closer to 0 in the x-axis, the higher the Km value. So the closer this one gets to 0, the higher the number. Okay. The higher the Km value, the lower the affinity. Right. Because remember here, it says it's inversely related to the affinity of the enzyme for its substrate. So if this is high, then this is going to be low. But if this is low, this is going to be high here. And here it's saying that same thing, right? Yeah, so if the affinity is low here, this is going to be high. So that's what they're saying here. The lower the affinity, the higher the Km value. Okay. So the competitive inhibitors cross each other, whereas non-competitive competitive inhibitors do not. So competitive inhibitors increase Km value, and that's what this is about, right? So in competitive inhibitor, you have the same Vmax but higher Km value. Okay, so Vmax is proportional to enzyme, right? So if they'll give you a diagram or a chart where they'll give you that they added 200 milligram of substrate and then 400, then 600, then 800 or something, right? And then at that point, the reaction that's happening across the board, like for drug A, drug B, drug C, or whatever, you'll see at like concentration of maybe 200, right? Because like drug A and B, A plus B, it will be at 200, uh, enzyme, sorry, yeah, so enzyme, and that would be the Vmax, because that's when you get the maximum uh, amount of reaction happening. But then, say if drug A plus drug B is causing drug A by itself is having reaction at like 600, or like you added 200 of drug A, and the reaction that's giving off is like just a number like 600, right? And then when you add drug A plus B, and now you need to add much higher. Uh, Wait, which higher? Now I'm confusing myself. I'm sorry. Okay, the closer to zero. Okay, so we just add that. Hold on. Let's just read my notes first. Uh, so then we'll look at this chart. So competitor inhibitor is higher in Km, but same Vmax. Okay, Vmax is proportional to the enzyme. Non Km value is inversely proportional to substrates. So the affinity of the enzyme for its substrate. Okay, non-competitor inhibitor is lower Vm and same Km. Okay, in competitive inhibitor, Km goes up, so closer to zero, right? So it's higher, and the closer it gets to zero, the higher the Km value, right? So you're gonna get Km as it approaches this line, it's gonna get closer to zero, so the Km value is higher, right? But this line, it crosses on the y-axis at the same point as this one, and that means the Vmax value doesn't change, right? So it's same Vmax here, uh, but higher Km value because it's closer. Sorry, lower Km, higher affinity of enzyme for its substrate. Okay, so and small Km will give you Vm reached at low concentration. Okay, yeah, so if you have, again, it's the same thing as this thing. So since it's closer to irreversibly related to affinity of the enzyme for substrate, so if enzyme for affinity for substrate is high, the Km value is low, right? And that makes sense because the affinity is going to be so strong that it doesn't need a whatever the Km value is. It's going to attach to the substrate pretty quick, right? So it doesn't have to do much work, and that's what it's saying here. Small Km will lead to Vm reached at low concentration. So that low concentration is good enough for the affinity. And then if there's large Km, Vmax reached at high concentration. So the maximum amount of reaction you're going to get is going to be at high concentration with a large Km, right? So that's all the way up here, kind of thing. So higher Km, lower the affinity. So V velocity equals Vmax divided by Kmax. Okay, we'll come to that later. So let's see what's here. So this is uninhibited, right? Oh yeah, we should keep that. Okay, so uninhibited. So here we have Km value over here, Vmax here. This is 1 over V, um, and this is the slope. That's Km over Vmax. Okay, so effects of enzyme inhibition. So for the uh, non-competitive, you're gonna have a lower Vmax, right? So the closer to zero it gets, the higher the Vmax. So the further it gets from zero, the lower the Vmax, right? So this is further away from zero than these lines when it's uninhibited, right? At least the pink one. So we have a lower Vmax here. Uh, why does that happen? It's because imagine this zero, so this is 1, 2, 3, right? So at 1, you have 1 over 1, so that's giving you 1. But here you have 3, so that's 1 over 3, not 3, right? So that's why. So 1 over 3 would give you a lower number. Yeah, okay, yeah. So 1 over 3 gives you a number that's lower than 1. That's why it's lower. Okay. Uh, and the closer it gets to 0, it's going to be higher. So 1 over 1 is 1, and then anything below that is going to be a bigger number than 1. Okay. And then you have competitive inhibitor. Uh, the In the competitive one, you have the same Vmax as the uninhibited one. So that's that point right there. But the Km value is higher, right? Because it's closer to 0. This part right here, the pink one is the uninhibited one, so this is the higher Km value, closer to 0 than this one. Whereas this non-competitive one, it has a lower Vm, right? Vmax right here, because it's above this line and it's further away from 0. And it has the same Km value because it attaches to the same point as the pink one or the uninhibited one. Okay. So what does that mean though? So, okay, um, let me draw that out real quick. Um, no, no hearts here while doing Pharmac. Okay. So say this is a substrate, this is an enzyme. So enzyme's gonna come in and attach over here, right? And that's the affinity, right? So how fast it comes in and attaches to this, right? That's the affinity. Now, say you have more than one, right? The chances of this reaction happening is based on the amount of substrate now, right? And then similarly, if you have more of these and less of these, the more substrate you have but less enzyme. Now it's dependent on this, okay? Or what can happen is there are two different types of substrates. So see, this one is, sorry, two different types of enzymes or substrates. Yeah, substrates. So this one, let's make this one like this color, right? Now they both are going to be going to bind to this site on the enzyme or enzymes, right? So that is competitive. So the more you have of different types going for the same one, that's called competitive inhibitor, right? Because now if this black goes with black, but then if this pink one comes in, it's going to block the attachment of this substrate to the enzyme or whatever, right? So that's the competitive inhibitor. Uh, then you have non-competitive inhibitor. That just means when this one attaches to a different site, like there instead of here. So this one can still attach to this, while this one attaches to something like here or something, right? I should make a different one. This attaches somewhere else. So that's a non-competitive inhibitor. So in competitive, when this one attaches here, it changes the structure of the this thing. So there is no site for this to attach to anymore. Whereas in non-competitive, it doesn't change the substrate. or enzyme. I forget which one it is, but hopefully that makes sense. Okay, so we'll do this and maybe that will help us. So competitive inhibitor, it's the reversible one. It resembles the substrate. Okay, so let's make that the substrate then. Okay, so that's the substrate. It's overcome by increase in concentration of substrate, right? Uh, so if we, yeah, so if this exists more, then this can only block so many, right? So say there are like four substrates and you only have two blockers. There's still other available for this one. That's why uh, if you increase the amount of substrates, it's still reversible. Like it's not going to block all of them. So the enzyme's going to still do its thing over here. Uh, Binds active site. This is the active site, so it still binds to that. Effect on Vmax is unchanged because this is dependent on how much you have. It's dependent on the substrate rate. Okay, so Vmax is proportional to the enzyme, right? So if this is substrate, this is enzyme, then it's proportional to the enzyme. That's the Vmax. So effect on Vmax is unchanged. Your enzyme is not changing, right? Your enzymes in your body don't change. So, or like in the experiment they're gonna do, it's gonna stay the same. So if you have like 3, the reaction that you're gonna get is gonna be an amount of 3, right? No matter how many substrates you add to it. As long as this is constant, you'll get a constant number for Vmax. Effect on Km value, however, will increase because now you have so many substrates floating around that enzyme doesn't have to spend time looking for it, right? So as soon as they go into the solution, it's going to start binding to the first one it sees. This is the first one it sees because there are so many substrates. So the affinity is going to be uh, really high, so the Km value will be low, right? Wait, I did that opposite. Yeah, the affinity. So the affinity of the enzyme for its substrate. Oh, sorry. Even with low affinity, yeah, that's what it means. Okay. So even with low affinity for between the substrate and the enzyme, uh, it's still gonna bind faster, right? Because it doesn't have to work that much. That's what it means. Okay. And then you have pharmacodynamics. So that's it decreases the potency. Okay, make sense of that. How you will. We'll do a look up a question for this after this. So competitive inhibitor irreversible. Uh, so in the irreversible one, it still resembles the substrate uh, when it attaches to it. Uh, overcame by Overcome by increase in substrate concentration. No. Okay. So even if you have more substrate, it's not going to make a difference. Bind active sites, yes. Vmax is decreased in this one, right? Because Vmax is proportional to the enzyme. So we'll do that later. Actually, let's do this one. Okay, let's just finish this then. Effect on Vmax is decreased. Effect on Km value is unchanged. And pharmacodynamics, decrease in efficacy. Okay. Non-competitive inhibitor resembles substrate. No. Overcame by increase. Okay, so it doesn't resemble substrate, right? That's what I meant. So after this thing attaches to this, uh, sorry, not this one, the inhibitor, non-competitive inhibitor attaches to it, it changes the structure. So this is going to change now, right? However, like even it doesn't even look like the same thing anymore. So no matter how much substrate you add, it's gonna keep changing. So it's not gonna uh, over be overcame. It binds active site. Since it's changed, the active site is gone, right? So it can't bind to the active site. Effect on Vmax. So again, Vmax is proportional to the enzyme. So effect on Vmax, it decreases, right? Because the effect decreases because the active site is not there. So what? No matter how much enzyme you add, there is not going to be affinity, right? You're not going to get the reaction. So once this changes, the reaction, you're not getting it anymore. Okay. Effect on Km value. So the Km value, it's unchanged because it's still, if you have this substrate still there, then it has the same affinity. The affinity hasn't changed, right? Between not this one, but the original one. It's still there. So if you provide this, it's still going to attach the same at the same rate and everything. Pharmacodynamics, there's decrease in efficacy because once this is changed, the reaction is not going to happen. So in competitive inhibitors, irreversible resembles substrate. It does. Overcame by increase in substrates concentration. It doesn't, because if once this attaches to this, the competitive inhibitor, uh, this is not gonna attach to that, I guess. So that's why. Bind active site, yes. Effect on Vmax is decreased, and so just normal, you know, the enzymes effect is decreased. I'm having trouble with that one. Let's see. Effect on Km value is unchanged and found. Let's look for a question for this. Okay, so this is the enzyme and this is the substrate. Okay, so when substrate attaches to the enzyme, you get the product. In competitor inhibitor, something else has came in and attached to the active site, so the substrate can come in and attach to it. You have non-competitive inhibitor. Substrate comes and attached to it, but the non-competitive inhibitor attaches to a different site. Okay, but the substrate can bind to it, but the reaction is blocked in that anyways, because it's not gonna happen. So that's a pretty good image. Graph with the velocity. Okay, so substrate concentration will be that. The rate of reaction is decreased. In competitive inhibitor, uh, it's not the same as before, but it still keeps going, right? Because in competitive, it's just whatever gets there first, basically. That's what it is. Allosteric site, enzyme 1 active site, and then you have an inhibitor coming in, attaching to it. Substrate going in and that, alter site, that, active. In allosteric activation, okay. So activator comes in, altered. Active site, so substrate comes in, attaches to the active site. Okay. So that comes. Non-competitive inhibitor, enzyme goes down. Okay, there you go. Alright, let's just finish this. Enzyme goes down, that means Vmax goes down. which means 1 over Vmax goes up. Okay, that was, we already figured that out on our own because we geniuses. Okay, the question is, okay, so biological effects of A, B, C, D, and E out of these. Okay. Antagonists are agents that bind to but do not activate receptors. Antagonists can be either competitive or non competitive. Competitive antagonists bind to the exact same. Let's look at the photo too. Okay, so antagonists can be competitive or non competitive. Competitive antagonists bind to the exact same receptors uh, binding site as endogenous or exogenous agonists, right? So if this one comes in, this also binds here. So binding sites as endogenous and exogenous agonists, thereby preventing agonist binding and activation of the receptor. Competitive antagonists can be reversible, ionic bond, or irreversible, which is covalent bond, right? So that's when what they're saying in this by reversible and irreversible. So competitive agonists binds to that. We did that. Competitive agonists can be reversible, which is an ionic bond, or irreversible covalent bond. The effect of a reversible competitive antagonist can be overcome by high concentrations of agonists. So if this is here, but you have a lot more of this, it's going to bully this one out. So this one can attach to it, right? Okay. So irreversible one. However, uh, and that is what, ionic, right? So in an ionic bond. But if it's a covalent bond, no matter how many uh, substrates you have, it's not going to bind to the enzyme. Okay. In a covalent bond. Okay. The effect of reversible competitive can be overcome by which cause displacement of the antagonist from the receptor by mass action. And non-competitive antagonists, on the other hand, bind to the receptors at a site other than the primary binding site, thereby causing a conformational or allosteric change in the receptor protein that modifies the agonist binding site and prevents agonist binding. By binding to a different site than the agonist, non-competitive antagonists are able to remain bound to the receptor even when high concentration of agonists are present, but the agonist is unable to displace non-competitive antagonists from the receptors, right? So in competitive, at least if you increase the substrate, you can do something about this in an ionic bond, of course. But over here, if this one binds to a different uh, site, the competitive inhibitor. So no matter how much substrate you have, this one has already changed the way this enzyme functions. So no matter how much substrate you have, or you know how many active sites it binds to, it's not going to make a difference because enzyme is not going to do its work. Which is why you get the where to go. Which is why what? Which is why what? In non-competitive, uh, you have the same Km value but lower Vm. So lower Vm, sorry, lower Vm means lower amount of reaction, right? With the enzymes, I guess. Yeah. The affinity doesn't change. The affinity, it still binds to the site as it did without this inhibitor. It's the same. There is no difference in that. So that's why you have the same Km value, but the reaction is lower because the reaction is not going to happen anymore. That's why it's that. Okay. I think I got a better picture now. Thank you for this. Uh, the agonist is unable to displace the. Okay. The question has asked how the curve for betanacol, curve A, would be affected by introduction of a reversible competitive agonist. Right. So the curve A. So agonist. Okay. A reversible competitive antagonist is expected to require higher doses of full agonists, right? So you need something that's going to be okay to be present to achieve the same effect at each point along the curve. If enough of the original substrate is added, the reaction can still reach the same maximum effect. Correct. Thus, the log dose response curve for a full agonist combined with a reversible competitive antagonist will exhibit a parallel shift to the right in the log dose response curve. Right, so it will go from here to here. The E one, I guess. With an increase in the ED50 and no change in the maximum effect. Right, so it's still the same effect, right? If you add more substrate to it, just the time it took is taking longer. Okay, so choice A. Curve A is the dose dependent curve from the original agonist drug in the absence of modifiers such as antagonists. So this is the original curve A. And then they're asking us, what are they asking? Reversible competitive agonist, competitive antagonist, sorry. Okay. So competitive, you have the same V max, so same amount of reaction. So the height is gonna be the same, but you're gonna have a higher Km value or increase in ED50. Right here, a non-competitive one, you have the same ED50. Okay. So both choices, both curves B and C represent the effect of adding a non-competitive antagonist to the agonist. Note that the ED50 is just half of this, I guess, where the reaction happens. At the like 50% of the substrate, the maximum reaction you can get at 50% of the substrate, I think. Okay, so both curve B and C represents the effect of adding a non-competitive antagonist to the agonist. Note that the ED50 is unchanged, that is, the ED50 from curve A, B, and C occur at the exact same log drug concentration. This is distinguishing characteristic of non-competitive antagonists. So they're talking about this too. They both start off at the same and have the same uh, growth up till here, right? C is literally half of A, right? But there's no shifting uh, from to left or right. Okay. So the maximum effect of or Emax of curve A, B, and C are reduced because the non-competitive antagonist has effectively reduced the number of receptors available for binding. The decrease in Emax will depend on the dose of non-competitive antagonist present and is illustrated by the difference between curve B and C, where a higher concentration of antagonist is present in the curve C than in B. Curve D illustrates a rightward shift in the dose response relationship, but the shift is not a parallel shift because the shape of the curve differs from the curve A. With changes in both Emax and ED50. This curve is not characteristic of any single antagonist effect and may be the result of adding multiple types of antagonists. Okay, so I'm not going to summarize that because it just became clear and I don't want to confuse you guys or me. So I'm just gonna move on from that. But thank you, that helped. Okay. So you have pharmacokinetics, bioavailability, fraction of administered dose reaching systemic circulation unchanged for a IV dose. So that's what it is. You take a drug, and how much of it is going to reach the system without being changed. So for an IV, it's reaching the system 100%, right? So without being changed. So IV has 100% bioavailability. In oral, F or bioavailability typically is less than 100% due to incomplete absorption and first pass metabolism. Uh, can be calculated from the area under the curve in the plot of plasma concentration over time. So when you take a drug, it gets metabolized, right? Uh, I just need to make sure first pass is. The phenomenon in which drug gets metabolized at a specific location in the body. Okay. So before it reaches the circulation, it can get metabolized by saliva, right, or lingual. It's put there, it can happen there too, and reach the viability from there. Or if it's going down the throat, it's going to go from saliva, and then you have it in stomach as well, and then it goes to colon, and then it gets absorbed there, and then it goes to the liver, where the final metabolism happens, and then it reaches the system, right? So you can imagine it's not going to be the 100% that you get from IV. So F typically is less than 100% due to incomplete absorption and first pass metabolism. Can be calculated from the area under the curve. So this curve right here for oral, and for IV it's all of this. So if they give you a curve like this, it's going to be the area under the curve that can help you with that. So I don't think you need to know this formula. Area under the curve, oral times dose IV divided by dose oral times area under the curve under the IV. So can be calculated from the area under the curve in the plot of plasma concentration over time. Volume of distribution. Theoretically, volume occupied by the total amount of drug in the body relative to its plasma concentration. Apparent volume of distribution of plasma protein bound drugs can be altered by liver and kidney disease. Decrease in protein binding or increase in volume distribution, volume of distribution. Drugs may distribute in more than one compartment. Hemodialysis is most effective for drugs with a low volume of distribution. Oh, 10 minutes and only 2 pages. Not even two. Okay. Volume of distribution, compartment and drug types, low, medium, and high. Compartment, if it's a low volume of distribution, it's going to be intravascular. So that's your large charged molecules or plasma protein bound. So you can imagine it doesn't distribute much because it can't leave the arteries to go into tissues and stuff, right? Or out of the arteries or vessels or whatever. So that's why volume of distribution is low. It can go all around the blood system, like in your arteries, but what it can't do is your blood can go through the arteries and exchange into the tissues, but this one is too large to go through those permeability filters. And also it's a fair also it's attached to the plasma protein, right? And then if the volume distribution is medium compartment, it can go to extracellular fluid, so it can leave the permeability of the vessels. These are your small hydrophilic molecules, and then you have high volume of distribution, which can go into all the tissues, including the fat. And these are your small lipophilic molecules, especially if bound to tissue protein. Okay. That's pretty straightforward. Volume distribution, know this formula. It's amount of drug in the body divided by the plasma drug concentration. So how much you have taken and how much of it is in the plasma. Because if it's not in the plasma, then it's the thing that's you know got distributed out of the plasma or out of the arteries or whatever. Arteries or veins, vessels. Clearance: the volume of plasma cleared of drug per unit time. Clearance may be impaired with defects in cardiac, hepatic, or renal function. Clearance is just the elimination of drugs, right? Divided by the plasma drug concentration. So you take some kind of drug, and then you check how much of it is in the plasma, and then whatever is not in the plasma. Uh, you take how much of it is in the plasma and how much is in the urine, I guess, right? And then you or how fast, like every interval you check, right? And then you can figure out the rate of elimination of drug, and then you divide it by plasma drug concentration, how much is in the plasma, and you get clearance with that. Which clearance also equals the volume of distribution times elimination constant, which is Ke. Sometimes they'll just give you this value, and then you have to figure this out, or they might just give you both of them, and then you just figure out this. It could be like that too. Half-life or T-half, the time required to change the amount of drug in the body by half during elimination. Okay, so this is an important concept to understand. So we'll just come back from the break. Because okay, so competitive inhibition, enzymatic activity. So normally this is the reaction you get, right? And then this is the competitive inhibitor. So this is ED50, right? Or I guess I don't know. It's like the half of whatever this was, and the half of this. It stayed at the same enzymatic activity, right? Because Vmax is the same. This is the Vmax. So that's the same. So then you're gonna have half point on the y-axis at the same as well. So all it's doing is shifting to the right. So what does that mean? The Michaelis-Menten model describes the behavior of enzyme-driven reaction by comparing the rate of reaction, which is V, to the concentration of the substrate. Maximal velocity, or Vmax, represents the speed at which the reaction occurs when the enzyme's active sites are completely saturated with substrates. The Km defines the substrate concentration, or Michaelis constant. It defines the substrate concentration at which half of the enzyme's binding sites are occupied by substrate, or half Vmax. So substrates with high affinity for the enzyme typically have a low Km. Yeah. Okay, so this is the plot. This is the Vmax. That's from the question we did earlier. Right. Okay. There's the Vmax on the y-axis. So this would be the half of Vmax, and this is the Km value. It's on the x-axis. So Km equals substrate concentration at half the Vmax. So this is half the Vmax. So whatever concentration, this is the line for substrate concentration. So whatever line it lands on, that's what the Km value is. Okay. Okay. So competitive inhibition occurs when an inhibitor binds to an enzyme, so here's the inhibitor binding to the enzyme, and prevents it from binding. Did you already read this? Binding the substrate. Most competitive inhibitors, including MLE, bind at the active site. Substrate binding pockets and physically impede substrate binding. Because these inhibitors compete with the substrate for binding to the active site, additional substrate is required to reach half Vmax. Okay, so since this is the substrate line, and the more you go towards the right, uh, there's that's how you can increase the amount of substrate. So when you go towards the right. So what they're saying is to reach the amount of Vmax, half the Vmax of the normal one without the inhibitor, you need a lot more substrate to overcome the inhibition, competitive inhibition, to create the same amount of Vmax, right? So additional substrate is required to reach half Vmax, thereby increasing apparent Km value. So this is why the Km value is increased. So it's a right shift. Competitive inhibitors have no effect on enzyme function, and therefore Vmax is unchanged. Vmax is unchanged. Okay. In this example, Vmax remains constant at 400, while Km increases from 8 to 16 in the presence of malate. Therefore, malate is a competitive inhibitor of succinate dehydrogenase for succinate. Okay, so they're gonna give you a chart for this one, and that's what this thing is talking about. The chart will have data on it, and the data is gonna go from like 0 to probably like 20 or 40, and then it's gonna show you the Vmax and the Km value for just the one without the drug B, and then you're gonna have drug A plus drug B, and then they're gonna have data for Vmax and Km value, and then you're gonna have to decide if it's competitive inhibitor or non-competitive inhibitor or something else to something else, right? So choice A, it was Vmax depends on how fast an enzyme can catalyze a reaction when there are enough substrate molecules to fully saturate its active sites. Competitive inhibitors do not affect Vmax as higher substrate concentrations are able to overcome the inhibition. Choice B was most competitive inhibitors such as malate bind in the substrate binding pocket. In contrast, most non-competitive inhibitors bind at allosteric sites. So that's different from the ones where substrate was binding, right? So it's like the designated site, resulting in a conformational change of the enzyme that decreases enzymatic activity and slows the rate of reaction, Vmax. Non-competitive inhibition does not change the apparent Km value, right? So it has the same Km value and cannot overcome with higher substrate concentration. Okay, so what it's gonna do is this it has the same ED50, so I gotta understand what ED50 is first. But anyway, so the Vmax is the one that changes, but the position on the x-axis, the substrate concentration, is not going to change for non-competitive, right? Because it has lower Vmax, so this is decrease in Vmax, but the Km value is the same over here. Okay, and there was choice B, which was choice C, which was irreversible inhibitors. So that's the competitive one again, the covalent one. Binds to the enzyme through strong covalent bonds. This typically renders the enzyme permanently ineffective, decreasing the Vmax. And then you had choice D. Competitive inhibitors interfere with substrate binding due to the inhibitor's own high affinity for the enzyme's active site. This causes the measured Km value to increase. However, the actual enzyme affinity for the substrate remains unchanged. So we went over that already. Alright, so there you have it. Alright, so half-life. The time required to change the amount of drug in the body by half during elimination. Steady state is a dynamic equilibrium in which drug concentration stays constant. That is, rate of drug elimination equals rate of drug administration. Okay, so that's the steady state. So, say you have a drug, and then it goes in, and let's say it's 100%, right? So it's IV drug. It goes in, and then so you give 100 milligrams of something in your blood, and then for that to become well, ml, not 100 milligram, but 100 ml of something, and for that concentration to become 50 ml in the amount of time is called the half-life, right? Because it's the time that we look at for it to become half. Okay, and then you have a steady state uh, where you have a pump that administers the drug in certain amount of intervals. So the amount of administered drug and the uh, rate of the drug administration uh, and the rate of drug elimination is the same. So if 20 milligram is going out and 20 milligram of ml of drug is going out, and then 20 ml of drug is going in as well, then that's called steady state. I understand ml is a lot, but just for the example's sake. In first order kinetics, a drug infused at a constant rate takes 4 to 5 half-lives to reach steady state. So you have to remember this is first order, importantly, and it takes 4 to 5 half-lives to reach steady state. It takes 3.3 half-lives to reach 90% of the steady state level. So it's saying that percent remaining. So you give 100% and then it becomes 50% of the initial one, right? Initial 100% at first half-life. Then at the second half-life, 50% of 50% or 25% of the initial 100% is 2. And then you have half of 25, which is 12.5, or yeah, 12.5. You have it at 3, and then at 4 you have 6.25%. Right, so that's like you already reached less than 90% on this one. So this was like 88% right there, around there. So it's saying in first order kinetic, a drug infused at constant rate takes 4 to 5 half-lives to reach steady state. It takes 3.3 half-lives to reach 90% of the steady state level. So T half-life equals, remember this formula? It's quite easy, you just gotta remember this, 0.7, right? Times volume of distribution divided by the clearance in first order elimination. Then there's also 0, so we'll do that over here. But just understand the concept of what this is. Okay, so 0.7 times volume of distribution divided by how much is eliminated or clearance. Okay. Then you have dosage calculation. That this is loading dose, and you have the target plasma concentration, which is Cp, times the volume of distribution divided by F. Maintenance dose is also F was bioavailability. So loading dose is again how much you the target plasma concentration, how much you want to make, times the volume of distribution divided by bioavailability of the drug. Maintenance dose is target plasma concentration times the clearance times the dosage interval if not administered continuously, and bioavailability. So I don't think they will test you on these much, but you should know what they are. They might say that there was a loading dose of this, but you will definitely test you on these. In renal or liver disease, maintenance dose, because from what I've heard, in steps they don't really worry about formulas, so they won't ask you anything too complicated. So they won't get down to these kind of calculations for you. What the maximum calculation you'll have to do is something in like finding out the RR or odds ratio or something like that. In public health, that will do, I think, tomorrow. Okay, so again, in renal or liver disease, maintenance dose decreased and loading dose is usually unchanged. Time to steady state depends primarily on T-half and is independent of dose and dosing frequency. Okay. So the half-life and is independent of dose and dosing frequency. Okay, so drug metabolism. Uh, Geriatric patients lose phase 1 first, and then you have patients who are slow acylators have increased adverse effects from certain drugs because of decrease in rate of metabolism. So again, geriatric patients lose phase 1 first, right? So this is your phase 1, and then you have patients who are slow acylators and have increased adverse effects from certain drugs because of decreased rate of metabolism. For example, isoniazid. So these are your lipophilic drugs. You have phase 1 and phase 2. This is predominantly cytochrome P450 independent. You have reduction, oxidation, and hydrolysis. And all of these will cause slightly poor or water soluble metabolites, active or inactive. And in phase 2, you have methylation, glucuronidation, acetylation, and sulfation. These are very polar metabolites except acylated metabolite. Okay. So phase 1 are basically, when it says predominantly CYP450 dependent, these are the drugs you know that get metabolized by CYP4 or cytochrome P450. Right. So that would be like your theophylline, cisapride. We'll do those. It'll come. So it also depends on the inhibitors and the inducers. So inhibitors would cause this to be slow, and then you have inducers, so then they get out of your system faster as well. So older patients won't have this phase, so they'll go to this, I guess. This one goes to the kidney basically to get excreted. Right, so acetylation, it's important in sulfalazine. Procainamide and hydralazine. These are the drugs that induce lupus as well, and they are slow acylators. It's found like in 50% of Caucasians and African Americans. These are just the notes that I have that I wrote in my book. They do ask you about this though. There is a question on this. Geriatric patient, it loses phase 1 first. So remember that, and patients who have slow acylators, they'll have increase in adverse effects. So just remember that as well from certain drugs because of decreased rate of metabolism. Okay, but this is the most important line that you should know. It loses phase 1, and phase 1 is predominantly cytochrome P450 dependent. It does is the reduction, oxidation, hydrolysis. Then we're at also, yeah, remember that the metabolites are going to be slightly polar, or also called water soluble, whereas phase 2 makes polar, very polar metabolites. So anything that's not here, which is reduction, oxidation, and hydrolysis, phase 2 does it. Okay, we have elimination of the drugs, zero order elimination. This is, so this would be your rate of zero order elimination. This is the first order. So zero order is rate of elimination is constant regardless of CP, the concentration of the drug. That is constant amount of drug eliminated per unit time. Okay, so that's what it is. So CP is constant amount of drug eliminated per unit time. So CP decreases linearly with time. Example of drugs that have zero order elimination is phenytoin, ethanol, and aspirin at high or toxic concentrations. Capacity eliminated elimination. So the more you have, the faster it gets eliminated, I guess. Or it decreases with time. Okay, it decreases with time. Okay, so the more you have, the longer it takes. Makes sense. Capacity limited elimination. PEA, a P is round, shaped like a zero, in zero order. Okay. So remember that. It's ethanol, phenytoin, and aspirin. Then you have first order elimination. Rate of first order elimination is directly proportional to the drug concentration, that is constant fraction of drug eliminated per unit time. CP decreases exponentially with time. Applies to most drugs. So the more you have, the faster it is, and the less you have, the slower it gets. Right. So, but here it's the same. The amount you have is the amount you do, no matter the amount of concentration in it. Right. So this is drug plasma concentration. You have 2 units here, and then you have time here in hours. So from 2 units to half of that, right, it took this amount of time, I guess. So first half-life, and half of that took the same amount of, well, not the same, but half of this time, that, and then the half of this took the half of this time as well, in the third half-life. So time of half-life decreases as concentration decreases. Okay, that's the main point. Okay, so in zero order elimination, remember this formula right here. So the time of half-life decreases as concentration decreases, but in first order elimination, time of half-life is constant as concentration decreases. So if your half-life is constant, it's first order, and if both the numbers are changing, it's zero order. So if one number stays the same in a chart, it's going to be first order. So you have 4 units, which becomes 2 units, which becomes 1 unit, to 0.5 units per hour. And this is first half-life, second half-life, and third half-life. Whereas the half-life here was 2, 1, and half. Here it's just 1, 1, 1. And it's a curve, so that should help too. figuring this out. They'll give you the thing actually. So they'll give you numbers, and then you have to figure out that the difference between the two half-lives is the same or not. So if the half-life for the first one was 2, and the next one is also 2, next one is also 2, it's going to be first order. But when you subtract the two numbers, you get 2 in the first one, and then you get 1 in the next one, and then half in the third one. Then that's going to be your zero order elimination. Okay. Urine pH and drug elimination. So ionized species are trapped in urine and cleared quickly. Neutral form can be reabsorbed. Weak acids, examples like phenobarbital, methotrexate, aspirin, which are salicylates. Trapped in basic environments, treat overdose with sodium bicarbonate to alkalize urine. So you have lipid soluble, this is trapped. Okay. Basically, just type that. Acids. Urine to excrete more drugs. Basis. Urine to excrete more drugs on a weak basis, right? Okay. So ionized species are trapped in urine and cleared quickly. Neutral forms can be reabsorbed. So in weak acids, examples are phenobarbital, methotrexate, and aspirin. They're trapped in basic environments. Treat overdose with sodium bicarbonate to alkalinize the urine. Okay, and in weak bases, it's trapped in acidic environments like you have your TCAs and amphetamines. Okay, so TCA toxicity is initially treated with sodium bicarbonate to overcome the sodium channel blocking activity of TCAs. This treats cardiac toxicity but does not accelerate drug elimination. That's why you gotta acidify it. Okay, then you have pKa. This thing, not really that important because it's like chemistry, and we only concern ourselves with biochemistry, if that. pKa, pH at which drugs, weak base or base, weak acid or base are 50% ionized and 50% non-ionized. The pKa represents the strength of the weak acid or base. Yeah, this doesn't get tested on, so I'm just gonna not spend time on it. Efficacy versus potency. Efficacy. Maximal effect a drug can produce. Represented by the Y value, Vmax. Increase in Y value equals increase in Vmax. Okay. So let's bring this back. Okay, so efficacy. Efficacy is maximal effect a drug can produce. So that's your Vmax, right? It's represented by the Y value. We know that already. If there is increase in Y value, that means that there is an increase in Vmax, which also means there is increase in efficacy. Unrelated to the potency, however, that is, efficacious drugs can have higher or lower potency. Partial agonists have less efficacy than full agonists, right? So it's just saying a drug can be can produce increased amount of reaction, but that doesn't mean it's that much potent. You might need like in drug A reaction can happen in like 200 milligram of something, and then there's like drug B which causes the effect you want in like 1 microgram, right? But they both can have the same Vmax, but the potency is different. Drug B, the 1 microgram, is more potent than drug A, which needed like 200 milligrams of something. Okay, so partial agonists have less efficacy than full agonists. So this is the difference between efficacy. Uh, the lower the Vmax, the better, right? Because the amount of time to reach Vmax here, the maximum effect, it took a. Actually, the shorter the Km value. Hold on. Let me not confuse you. Hold on. Let me just think about this. Oh, they explain it here. Okay, so we'll just think about that. Yeah, the faster the potency it achieves Vmax at, and being the same potency, that would be better. But if one is more potent than the Vmax, even if it's lower, it's fine. You know, that's what I saw or thinking. Potency, amount of drug needed for a given effect. Sorry. So amount of drug needed for a given effect, represented by the X value or the EC50. Left shifting decreases the EC50. So if there's a left shift, that's the increase in potency. So not the Km value, but the EC50 value. Okay. So left shifting decreases EC50, which increases the potency. So that's basically saying the amount of effect this thing takes to get to for the optimum effect. This one takes less amount of time to do the same thing, right? So it's more potent. Drug A is more potent than drug B. Unrelated to efficacy though, that is, the potent drugs can have high or low efficacy. Right? So that same thing. Maximal effect of drug can produce its efficacy. EC is effective concentration, and that was the log dose maximum effect. Cool. Okay. Let's make this smaller. Okay. So receptor binding. Let's see if we get it now. This is the percent of maximal effect. This is agonist dose. Similar here, similar here. Okay, so agonists with competitive antagonists or competitive inhibitors, the potency is decreased, right? The affected, not the effect, but like, yeah, the given effect you wanted, right? Yeah, the given effect is gonna be decreased because now it can only do, because half of the active sites are blocked, right? So it can only present the effects and on the sites it can do. So the effects are like halved from the initial ones. Okay. So potency is decreased, efficacy there's no change. Remarks can be overcome by increase in agonist concentration. An example is diazepam agonist plus flumazole, competitive antagonist on GABA receptors. So you have diazepam, which are the agonists, and then you have flumazenil, which is a competitive antagonist. So this one you give so that you have these don't get broken down, I guess, right? So the effect of this lasts longer because once this attaches to the enzyme, it's going to get cleaved or broken up. So rather than having it break down and having it last longer in the system, we give flumazenil, which is a competitive antagonist on GABA receptor. GABA is the inhibitory one. Right? So here we have agonist, and then you have agonist plus competitive antagonist. Right? And so the potency is reduced. However, the effect is the same. Right? The Vmax, at least. And then you have non-competitive antagonist with potency. There's no change. However, the efficacy is decreased, right? Because now the whole substrate has changed, right? The enzyme with the substrate has changed. So even if it binds, there's no point. So potency is still there, but your whole enzyme is like decreased. So efficacy is decreased. Cannot be overcome by increase in agonist concentration, because no matter how much you add, as long as the enzyme is still changed, you're not going to have a reaction. Example, norepinephrine plus phenoxybenzamine. I think that's like an alpha blocker. Oh, okay, yeah. It's given. Phenoxybenzamine, non-competitive antagonist on alpha receptors. Okay. So you have this with the efficacy reduced now, because the whatever half of this was, it's reduced to this, so it's decreased. So when something decreases in y-axis, efficacy is reduced. And then you have partial agonist alone. Potency is independent, and then you have efficacy, which is decreased because this is agonist by itself, and this is the partial agonist. So it's following this similar path, but the efficacy is reduced in the y-axis. Over here, the potency is reduced as it's doing a right shift as well, sort of. Right, so independent potency. Because it's starting all the way here compared to here, but then, yeah, so okay. Acts at the same site as full agonist, morphine, full agonist versus buprenorphine, partial agonist at opioid mu receptors. Okay. Just know that the y-axis is efficacy, left and right shift is the potency. And what happens in competitive? You get potency reduced. In non-competitive, you have the efficacy reduced. So a drug given that it's going to block and it's not going to work even if you increase the concentration of it. And then you have partial agonist, where my mind can't comprehend this. So it's morphine full agonist versus buprenorphine, which is a partial agonist, at opioid mu receptors. So they both are agonists. Nothing is blocking nothing. It's just that you'll get independent potency because independent reactions are going to happen. Therapeutic index, measurement of drug safety. So you have toxic dose 50 and effective dose at 50. So toxic divided by the effective. So median toxic dose divided by median effective dose. So this is how you measure the drug safety, right? So therapeutic, you have a therapeutic window, the range of drug concentrations that can safely and effectively treat the disease. Okay, so it's going to be a balance between efficacy and potency, I guess, but because it has to be potent enough to create the effect you want, but it can't be so like it has to reach before the concentration reaches toxic amount. Right? So type therapeutic index equals T over E, or T50 divided by E T50. Safer drugs have higher T1 value, TI value, therapeutic index value. Okay, and drugs with lower TI value frequently require monitoring. So higher TI value, that's increase the top number, so increasing this number or lower this number. So basically you have a bigger window. So the bigger the window is, the safer the drug is. That's what we're saying. Drugs with lower TI value, so the bottom number is higher or the top number is lower, right? So the shorter window. So the shorter the window is, the therapeutic window is, the it will require monitoring. Okay, so drugs with lower TI values frequently require monitoring. For example, warfarin, theophylline, and digoxin. And then you have antileptic drugs and lithium as well. So warning, these drugs are lethal. Know these drugs. These drugs have low TI, right? So it's important because it requires measurement of levels to avoid toxicity. So these are your warfarin, digoxin, lithium, theophylline, antileptic drugs. Okay. So yeah, therapeutic window, effective dose, toxic dose, percent of patients responding, log drug concentration. So bigger the window, the better. The smaller the window, the more monitoring it's going to require. Okay. Don't need this anymore. Okay. So we have drug effect modifications. These are the terms, definition, and examples. Additive, effect of substance A and B together is equal to the sum of their individual effects. Aspirin and acetaminophen, 2 plus 2 equals 4. Permissive, presence of substance A is required for the full effect of substance B. And so, cortisol on catecholamine responsiveness. Synergistic is effect of substance A and B together is greater than the sum of their individual effects. So substance A would produce X number of amount, and B would cause Y number of reactions to happen, and with X plus Y you get bigger than X and Y kind of thing. Okay, so you have 2 plus 2 is more than 4 kind of thing. Cool. Remember synergistic because that's an important one. Potentiation is similar to synergism, but drug B with no therapeutic action enhances the therapeutic action of drug A. So drug B by itself has no goal in life, but when it meets up with drug A, it helps it like a life coach to do better. So carbidopa only blocks enzyme to prevent peripheral carbonization, conversion of levodopa. Okay. Because basically levodopa, it gets converted in the system as well as in the brain. But we want it to get converted in the brain, right? Because after the conversion happens, dopamine outside of the brain cannot cross the blood-brain barrier. That's why we give it in levodopa. So if it gets converted in the body, then there's very little that's gonna leave for the brain to have, right? And then whatever amount it reaches the brain, basically, it will convert it into that. So what carbidopa is, it doesn't cross blood-brain barrier. It only stays in the system. So carbidopa will then prevent the conversion of levodopa to dopamine. So when this thing reaches the brain, it will get converted there, but not in the system. So 2 plus 0 is more than 2 as well. Antagonistic effect of substance A and B together is less than the sum of their individual effects. So ethanol antidote for methanol toxicity, 2 plus 2 is less than 4. So substance A and B together is less than. So substance A produces X amount and B produces Y amount, and then when you add them both up, it's going to be A minus B amount. Tachyphylactic, acute decrease in response to a drug after initial or repeated administration. Repeat use of intranasal decongestant, for example, oxymetazoline, will have decreased therapeutic response with rebound congestion. This is, I think, medicamentosa or something. The condition. Medicamentosa. Is that what it is? Well-recognized condition of chronic nasal congestion associated with overuse of vasoconstriction nose drops. It is thought to be due to rebound nasal mucosal edema, which may occur after use of topical nasal vasoconstriction even for a short period of time. Yeah, so rhinitis medicamentosa, that's what it is. Tachyphylactic. More use it, the less therapeutic effect it has. Okay. Now the fun stuff starts. Pharmacology and autonomic drugs. Wow, that's not a good sign if I'm already pronouncing it wrong or reading it wrong. Okay, so we have autonomic receptors. There's parasympathetic and sympathetic, right? So parasympathetic is gonna include anything that's going into stuff that is not sent. No, sorry. Parasympathetic is the one where it's the relaxed one. So everything that happens while you're relaxed, and sympathetic is the one where things happen when you're in your fight or flight one, right? But for now, let's just do this. So you have a brainstem, and you have acetylcholine, and you have nicotinic receptors, and this is the post synapse, acetylcholine, and M. So that's your muscles or muscular receptors, M receptors. Smooth muscle, gland cells, nerve terminals, and cardiac muscles. Okay, so all of these have a short post acetylcholine. Okay, and then we have sympathetic, which is a spinal cord one. They have pre-short, but a post synapse is long. Acetylcholine nicotinic receptors here, and then at the end of it, this one is ACH, M sweat glands, and then you have neurotransmitters, and then of NE, and then alpha 1, alpha 2, beta 1, smooth muscle, gland cells, nerve terminals, and cardiac muscles as well. This one goes to dopamine 1, neurotransmitter, and then renal vasculature and smooth muscle. Here you have acetylcholine, again, adrenomedulla. The important thing here is that it doesn't have a post, it just has a pre-short, pre-synapses, so that's important. Catecholamine transmission, norepinephrine goes to, again, the alpha 1, 2, and beta 1, and this one goes to alpha 1, alpha 2, beta 1, beta 2, cardiac muscles and vessels. Okay, so what's the difference then, right? Well, let's see what they say. Mostly it's that this one is going to the muscular ones, and these ones predominantly is the alpha and beta ones receptors, right? So pelvic splenic nerves. Hold on. Okay, 10 minutes. Let's finish this page. Pelvic splenic nerves and cranial nerve 3, 7, 9, and 10 are part of parasympathetic nervous system. Okay. 3, 7, 9, 10 are part of parasympathetic nervous system. So that's your oculomotor, facial, glossopharyngeal, and vagus. Okay. Adrenomedulla is directly innervated by preganglionic sympathetic fiber, and sweat glands are part of the sympathetic pathway but are innervated by cholinergic pathway or fibers. Sympathetic nervous system results in a cold sweat. Acetylcholine. Nicotinic acetylcholine receptors are ligand-gated channels allowing efflux of potassium and influx of sodium, and in some cases calcium as well. Two subtypes. There's NN. It's found in autonomic ganglia, adrenal medulla, right there, and NM, found in neuromuscular junction of skeletal muscle. That one right there. Sorry, we forgot about this one. Somatic. Voluntary motor nerve, so acetylcholine, and NM, skeletal muscles, neuromuscular junction right there. Okay. Muscarinic acetylcholine receptors are G protein coupled receptors that usually act through second messengers. 5 subtypes: M1, 5 found in heart, smooth muscle, brain, exocrine glands, and on sweat glands. Okay, so right there and right there. Okay, so sweat glands are part of sympathetic pathway, even though it's muscarinic. Okay, and it's pathway but innervated by cholinergic pathway. Remember that. Okay, and we have nicotinic acetylcholine receptors and we have muscarinic acetylcholine receptors. The nicotinic ones, they work from potassium and sodium influx and outflux, efflux, whereas muscarinic ones, they function via G proteins. We'll go over that in the next session. Okay. Acetylcholine receptors. So nicotinic is based off of potassium and influx of sodium, right, and calcium. So that's how those work. But what about the muscarinic? So muscarinic are the ones G-coupled proteins, right? So that's this stuff. So the GS stimulates adenyl cyclase, GI inhibits adenyl cyclase, and GQ contracts vascular smooth muscles. So the alpha, so these are the G proteins, GS, GI, and GQ. And then we have complex of gamma, beta, and alpha up here. And the alpha attaches the GDP and then converts it to GTP, and this complex right here is what interacts with the second messengers. So the GS and the GI. So GS activates adenyl cyclase, whereas GI, I for inhibits or inhibitory, inhibits adenyl cyclase. So when you have GS and adenyl cyclase attached to adenyl cyclase, the complex then converts ATP to CAMP, and CAMP then goes on to doing its thing. So it could be pKa or activating CFTR, right? We did that in micro. And then we have GI, which inhibits adenyl cyclase. So if it's inhibited, then you're not going to get ATP to CAMP. So then you're not going to get pKa to do its thing. So these are the hormones that use this system, FSH, LA. So these endocrine hormones under the influence of CAMP. So that's this whole thing, right? So FSH, LH, ACTH, TSH, CRH, HCG, ADH on the V2 receptors. Those are the ones in your renals. MSH, PTH, calcitonin, GHRH, glucagon, and histamine, the H2 ones. Then you have GQ, which has its own thing. So again, you have gamma, beta, and alpha, and then the complex is attached to GDP, which converts it to GTP, and this complex interacts with GQ, and then the GQ interacts with phospholipase C to convert PIP2 to IP3 DAG, right? You probably heard that before. So you need phospholipase C to convert PIP to IP3 DAG, and then you have IP3 go into the cell and activating calcium receptors to have calcium getting released from the sarcoplasmic reticulum into the cytoplasm. So under the influence of IP3, you get activation of PKC, or protein kinase C. Okay, so these are the ones that use GnRH, the system. So GnRH, oxytocin, ADH, the V1 receptors, and TRH, histamine H1 receptors, angiotensin 2 receptors, and gastrin. So all this will come across in endo as well. And there's also one about guanylate cyclase. We don't have to worry about this here. It was in micro. But again, NO, guanylate cyclase, GTP converts to CGMP and makes PKG. So those are your second messengers. Okay. Micturition control. So you have micturition center in pons regulates involuntary bladder function via coordination of sympathetic and parasympathetic nervous system. Positive sympathetic, increase in urinary retention. Positive parasympathetic, increase in voiding. Positive parasympathetic, is that what I said? Increases with urine voiding. Some autonomic drug acts on smooth muscle receptors to treat bladder dysfunction. Before we do this, let's understand the receptors first, and then we'll come back to this page. Okay, so we have G protein linked messengers. So this is alpha 1, 2, 1, beta 1, beta 2, beta 3, M1, M2, M3, D1, D2, H1, H2, V1, V2. So how we remember it is this thing right here. But I have my own thing, so we'll be looking at that. And my own thing is over here. I thought I had it. Yeah, right here. Okay, I do have it. Kiss. Okay, so that's the one I use. Okay, so you have kiss, right? So this is have one M&M. That's the mnemonic for that. So have one is H1, A1, V1, and then M&M. So that's M1 and 3. Okay, so again, so that's H1, right? So H1 is Q, A1 is Q, V1 is Q, and M1 and M3 is Q as well. So have one M&M. That's a good mnemonic. That works for me. Then we have for inhibitory or I, that's MAD2, MAD. So M2 is I, A2 is I, and D2 is I. Right, so MAD2. And then you have S, B1, B2, D1, H2, and V2. Right, these are all the other ones that are left over. So B1 is S, B2 is S, B3, I guess, they added this. And then you have D1S, H2S, and V2S. It could be that because B3 is not really that important besides the one we're going to do right now. Okay, so as long as you remember this, you won't forget it. So have one M&M, MAD2, and all the others. Right, so as long as you remember it's these, and then these ones don't go into this, right? So B1 doesn't fit in, B2 doesn't fit in here, D1, H2, or V2. You'll remember that, what Q is and I is. Okay. So okay, so we have GS, we have GI, and GQ. GQ is the one that's converting PIP to IP3 DAG, and GS activates and makes CMP. GI, you know, doesn't make CMP. Okay. So what do these do? These are basically, you just gotta think of it like, does it increase the action or does it decrease the action? And then you don't have to worry about remembering individual things about it. So alpha 1, it's known for contraction, so it's going to contract everything. Okay, so you have increase in vascular smooth muscle contraction, increase in pupillary dilator muscle contraction, so that is called mydriasis. So don't confuse it with meiosis. So so hmm, basically these muscles right here, they're the ones contracting. So if they contract, this is going to go towards it, right? So you're going to get a bigger pupil, and that's why you get mydriasis. Because the bigger the pupil, the more light can come in. The more light can come in, the more information you have to process and act in case you are in a fight or flight response, right? So this is a sympathetic one. Okay. Uh, So then you have increase in intestinal and bladder sphincter muscle contraction as well. So there you go, intestinal and bladder sphincter. So we have A1 somewhere here, right? Right there. So these sphincters are A1 receptors, okay? And the A1 does what? We just did that. It contracts, right? So if it contracts, it's going to prevent this from going out. Okay, so A1, vascular smooth muscle and visceral smooth muscle vasoconstriction, and as well as smooth muscle contraction. Okay, so again, increase in intestinal and bladder sphincter muscle contraction. Then we have A2, which is GI, so it's inhibitory, so it's going to inhibit the contraction or inhibit other stuff from releasing. Okay, so you have decrease in sympathetic or adrenergic outflow, decrease in insulin release, decrease in lipolysis, increase in platelet aggregation, and decrease in aqueous humor production. Everything's going to be decreased. So individually, you don't have to remember each and everything. Just remember its overall action is to increase or inhibit stuff. Right. Then we have B1. One is for heart, and 2 because you have two lungs, right? So B1 you know from beta blockers. So B1 uses G protein class S. That's this one. So it uses GS to make ATP and CMP to do its thing. So this will increase heart rate, increase contractility, one heart, increase in renin release, and increase in lipolysis. So if beta 1 does this, it increases heart rate and contractility. That's why I give beta blocker to reduce this in case of tachy or increase in BP and stuff like that. Because what does renin do, right? That's what it does. So we can give it in BP as well. Um, so remember that B1 has effect in kidney as well. Then you have B2S, vasodilation, bronchodilation. So you have two lungs, so that's why it's B2. But basically, this is gonna everything. It's gonna decrease. So this was increasing everything, B1, and this is gonna decrease everything. So by decreasing, I mean vasodilation instead of contraction, bronchodilation instead of contractions. That's why what is asthma, right? It's narrowing of the airways. So when you do bronchodilation, you feel better. So that's why we give uh, beta 2 agonists. Then we have increase in lipolysis, increase in uh, insulin release, sorry, and then so lipolysis is in other words is just breakdown of fatty acid, right? So it decreases the amount of fat you have, so you can think of it that way. Insulin, so it decreases the amount of glucose you have, right, uh, in the bloodstream. And then glycogenolysis, so that's breakdown of glycogen, I guess. Decrease in uterine tone, and then you have increase in aqueous production, humor production, and then you have increase in cellular potassium uptake. For B2, remember the lung ones. Those are the important ones. For B1, it's all about the heart. It's easy to remember. Right. Then you have B3. Again, it uses S. So increase in lipolysis, increase in thermogenesis in skeletal muscle, and increase in bladder extraction. This one is not really asked that much, besides just here. So this is where you're gonna find it, B3 receptor. Right. Then we have, so these were adrenergic, right? So those are your alphas and betas. And now we have cholinergics. So cholinergics are the muscular ones. So M1, 2, and 3, they use IP3 DAG, and it rely on calcium to function, right? So M1Q mediates higher cognitive functions, stimulates enteric nervous system, right? That's your like intestinal stuff or stomach stuff, abdo stuff, enteric, and then you have nervous system there. So that's what it stimulates. Then you have M2I, or GI protein, which inhibits everything, so decrease in heart rate and contractility of the atria. Then you have M3, again Q. So whatever calcium does to it, you can think of it that way. So increase in exocrine gland secretion, lacrimal, sweat, salivary, gastric acid, increase in gut peristalsis, increase in bladder contraction, constriction, sorry, increase in pupillary sphincter muscle contraction, so that's meiosis. Okay. And then you have, so pupillary, don't screw that up. Pupillary and the mydriasis. This is dilatory, right? So it's known to dilate. So it's those muscles that this A1 acts on, and this one acts on sphincter muscle contraction, just the pupillary sphincter muscle contraction, which causes meiosis. So let's just have a look at what that is. Okay. So it's these things. Okay, so you have pupillary dilator muscles. So that's the one used for mydriasis. And then you have sphincter constrictor muscles right here, and which constricts the pupil basically. So that's how you get constrictors contract. So you get meiosis, and when dilators contract, you get mydriasis. Okay. And then you have ciliary muscle contraction or accommodation, increase in insulin release, and endothelium mediated vasodilation. Okay, so again, 1 and 3 was in have one M&M. Right. Right. Keep that up here. Dopamine. Dopamine. Uh, D1 is part of S and D2 is part of I, right? So it's MAD2. So D1 S. S is this thing again. It uses CAMP. So it relaxes. This one, where were we at? I think dopamine, right? So dopamine 1 uses S, this thing. It depends on CMP to function. So it relaxes renal vascular smooth muscles. So in D1, D1 is known as excitatory, and then D2 is known as inhibitory. But its function is opposite to what it is known for. So yeah, so the excitatory one is gonna cause relaxation, uh, renal vascular smooth muscle, and it activates direct pathway of striatum, right? We'll do that when we do basal ganglia. And then we have D2, which is inhibitory. So it modulates transmitter release, especially in brain, inhibits indirect pathway of striatum. Okay, so when I said inhibitory and excitatory, ignore it. It's not as confusing. Just remember, D1 relaxes it and it activates direct pathway of striatum or basal ganglia, and then to the thalamus basically. And then we have D2, which is inhibitory, which inhibits indirect pathway, right? So when you inhibit something that's already inhibiting, it's gonna cause what? Activation, right? So that's what I was saying. We'll do that when we come to it. In CNS modulates transmitters release and especially in brain. Then we have histamine, so that's part of HAV1 and all the others. So S. So H1 is Q, and then H2 is S. H1 is Q, so it's gonna be again this one. This thing activates. So what's it gonna do? Increase in nasal and bronchial mucus production. Is going to increase vascular permeability and vasodilation, bronchoconstriction, pruritus, and pain. So it's going to increase everything. And histamine, it's related to your allergies and stuff. So whatever happens there, those are the components that are going to get increased. So you have nasal and bronchial mucus production. You're going to have increase in vascular permeability, and vasodilation, bronchoconstriction for asthma, and then you have pruritus for skin allergy, and then pain because of, I don't know, allergy to punches. Then you have H2S, which is there is increase in gastric acid secretion. This is, so we'll do this in GIT, but these two are different, right? So H2 is for increase in gastric acid secretion, so that's also GS, right? Sorry, this one was GQ, not. I'm losing my mind. So this was GQ, so it uses calcium to do its things. Right. IP3 DAG. And then we have this using CAMP. I'm sorry about that. Then we have vasopressin. That's V1 GQ, increase in vascular smooth muscle contraction. Again, uses calcium in the muscles. And then we have V2 in the kidneys or renals, which uses CAMP, uh, increase in H2O permeability and resorption via upregulating aquaporin 2 and collecting tubules of kidney, and there's increase of von Willebrand factor as well. So this is a chart we were looking at, but I like mine better, but this is also there, so we'll look at that. So receptor, and then you have GQ. Should I just do it side by side? I think that'll be better, right? I'll bring this one there. Okay, so we're doing GQ first, so that's this one right here. So you have receptor up there, uh, and all of this interacting with GQ, which interacts with phospholipase C, and phospholipase C. You have lipid secreting PAP2 or coming PAP2 coming from lipids, and then in the presence of phospholipase C, it makes IP3 and DAG, right? So IP3 plus DAG, and then what does DAG do? It makes protein kinase C, and then you also have IP3 DAG making increasing the intracellular calcium from sarcoplasmic reticulum, so it excretes. Well, it doesn't excrete, but it leaks out the calcium when this comes into the cell. And then you have, because of the calcium, smooth muscle contraction. And this calcium also activates the protein kinase C. So that's activation of protein kinase C under the influence of IP3. Okay, and then you have receptor GS and GI, right? So GI with adenyl cyclase, going from ATP to CMP for that, and then CMP makes protein kinase A. And here you have GI. Oh, I did that opposite, didn't I? But yeah, that. But this one will inhibit adenyl cyclase, so it won't make this. So you won't have CMP to make protein kinase in GI pathway. So protein kinase A, what does it do? It can increase calcium intracellularly in the heart, and then you also have it inhibits myosin light chain kinase. This is the smooth muscle contraction part. Okay. So the GS one. So remember, that's why in beta 1 it uses S to increase the heart rate and contractility, right? Because then you have calcium in the heart. So calcium, even GS causes increase in calcium intracellular. It's not just this one. Okay, let's go back to this now. Hopefully things will make more sense now. So we have micturition control. Micturition center and pons regulate involuntary bladder function via coordination of sympathetic, so that your fight or flight response, and then you have parasympathetic, that's your relaxation response, nervous system. So positive sympathetic will cause increase in urinary retention, because when you're running away, you really don't need to pee, right? So it increases urinary retention. But when you're relaxed, like listening to my voice, you have increased urine voiding happening, so you're feeling the pressure there. Some autonomic drugs act on smooth muscle receptors to treat bladder dysfunction, right? So you have some autonomic drugs act on smooth muscle receptors to treat bladder dysfunction. Okay, so we're going to learn about this now. Before we do that, let's learn about the anatomy. So these are the detrusor muscles. Those are your contracting muscles outside of the bladder, right? And then you have pelvic nerve, parasympathetic input, that uses M3 receptor. So we already did what that was. That's it uses Q, right? M3. It uses Q because it's in have one M&M. So that will increase everything because calcium, right? And then you have hypogastric nerve or sympathetic input, and these use beta 3 receptor and also alpha 1 receptor. So this one is known for contraction, we already know that one. Beta 3 was also, I think, S, or what was it? Yeah, S. So that will also do increased stuff, right? So this one increases bladder relaxation. Okay. And that's different to increase in bladder sphincter muscle contraction. Okay. So basically, if this one is contracted and this one's relaxed, you're retaining your fluid inside, right? So if this one is relaxed, B3, and this one is contracted, you're not going to get leakage. It's when this one relaxes and this one contracts, you're going to get leakage, right? So to contract, it's this one, and to relax, it's this one. Because sympathetic, you needed this to relax, so it retains the urine. So when you're running away, you also are not, peeing while you're running. Then you have pudendal nerve, somatic, nicotinic receptor, right there, which is not going to be talked about. So the three ones that we are concerned about is M3, beta 3, and alpha 1. This is the internal urethral sphincter, and this is the external urethral sphincter. Okay, so let me make that smaller. Okay, we have muscarinic antagonists. So this is oxybutynin. Okay, so oxybutynin, negative M3 receptors, or inhibiting M3 receptors will cause relaxation of detrusor smooth muscles, right? So this will lead to decreased detrusor overactivity. Because remember, M3 uses what? GS, and GS is going to be about calcium. Calcium will cause contraction in anything, right? So when you block that calcium or M3 because of GS, again, M3 was GQ, sorry, I keep messing it up, is KISS. GQ, but same thing, it uses calcium. You will get contraction. So you block that whole thing, so then it doesn't contract, so you get relaxation. So we use it for decreasing detrusor of activity. So application is in urgency incontinence, right? And oxybutynin. So for this one, you just remember it with O for oxy, butynin is for overactive bladder. Okay. So let's do these and these blue. so oxybutene is for overactive bladder. Okay, and then we have muscarinic uh, agonists, for example, betanocol. So you have, if you activate the M3 receptor, it's going to cause contraction of detrusor muscle, so you have increase in bladder emptying. So this one you would use for urinary retention. For this one, it was right. So it was okay. I got it. Give Beth the call to unclog the pipes. Right. So urinary retention. Again, I only do this because I have a hard time remembering the drugs. If you remember it, don't do this. But it does help. So oxybutyn was for use. It's used for overactive bladder. Give Bethacol to unclog the pipes. So, because unclog as in increased bladder emptying. So it's used for urinary retention. Then you have sympathomimetics. For example, mirabegron or mirabegron. So you're activating the B3 receptors. Again, B3 is S, right? Before I make that mistake again, yes, it's S. So CAMP, protein kinase A to calcium intracellular. So when you activate it, you're gonna get relaxation of detrusor smooth muscle, right? And you get increase in bladder capacity. Again, B3, increase in bladder relaxation. Then right, so this is used in, again, urgency incontinence. So for this one, I had in Hindi, I just say it, Mera bladder has grown. But it also works in English if you just make it my bladder has grown instead of me. Actually, yeah, that works too. So me bladder has grown. So Mira be grown is me bladder has grown. So when it grows, it increases bladder capacity, right? So it's a sympathomimetic. Remember, sympathomimetic is for fight and flight. So fight or flight, you want to retain urine for that, right? So you're going to retain it. So that's increase in bladder capacity is going to do that. That's why it's called sympathomimetic. Okay. Then you have alpha 1 blockers, tamsulosin. It's decrease or inhibiting alpha 1 receptor. We know alpha 1 does what? It contracts. So when you stop the contraction, you get relaxation of smooth muscle, bladder, neck, and prostate, which leads to decrease in urinary obstruction, right? So application is BPH, basal benign prostatic hyperplasia. So for this one, it was what was it? Relaxation of smooth muscle, bladder, neck. I'm trying to think of a way to do this in English because I did it in Hindi, or my language, which is Gujarati. But I guess tame the losing. Interleucin? I don't know. At this point, I just remembered by itself, so due to that one. Alpha 1, it's a contractor, right? But if you inhibit it, it's going to relax it. You don't need to remember that stuff if you just know the mechanism of this. And tamsulosin is an alpha 1 blocker. So, I like making acronyms, so I can't stop thinking about this one. Maybe I'll do it with Greg. So, tissue distribution of adrenergic receptors, receptor, tissue, and effects. You have alpha 1, again, is contractors. So, on vascular smooth muscle, it'll cause vasoconstriction. Visceral smooth muscle, it'll cause smooth muscle contraction. Right? And then you have alpha 2, which is what? Relaxers or dilators, right? Right here, it's inhibitor. So it's GI, so GI inhibits everything. So it's gonna block the CMP, so you won't have the calcium intracellularly. So yeah, in pancreas, presynaptic terminals and salivary glands, inhibition of neurotransmitter release. Then you have B1, heart and kidney. Uh, Remember I told you B1 has effect on kidney as well, so remember that because it increases renin secretion and heart rate. And then you have B2, bronchioles, cardiac muscle, liver, visceral, smooth muscle, bronchodilation, increase in heart rate. This is also S, right? So, but it acts on the muscles that dilate stuff. So, bronchodilation, increase in heart rate, and contractility, inhibition of insulin secretion, and vasodilation. Okay, so it's gonna decrease everything. You can remember this if you remember that B2 is in the lungs, and we give beta 2 agonists to cause bronchodilation. And then you can get to vasodilation from there, and then it's beta, so heart rate and cardio contractility. So this is selective, and I guess this is non-selective because that's both beta 1 and beta 2 effects, because this is literally beta 1 effect, right? Okay, then you have B3, adipose. It increases lipolysis, so usage of fatty acids. Okay, so we got through that. Now it doesn't get more complicated than that. So if we got that, everything else should come easier now. Autonomic drugs, release of norepinephrine from a sympathetic nerve ending is modulated by norepinephrine itself, acting on presynaptic alpha 2 autoreceptors, so it will give you negative feedback. Again, release of norepinephrine from a sympathetic nerve ending, right? Sympathetic nerve ending is fight or flight response ones. So when it does it from there, it's modulated by NE itself, acting on presynaptic alpha 2, right? So alpha 2 is the relaxer one. It will give you a negative feedback. Okay, so let's look at that. So you have NE coming out, and then it's out here. And if there's too much of it, it's going to have a negative feedback going to alpha 2. And then what's alpha 2 going to do? Alpha 2 is a relaxer, right? So, because remember it's QIS, and then I was MAD2. So MAD2 has A2 in it. So I'll keep doing this so we remember it by the end of this chapter. We all will have this in our heads. Okay, so MAD2 is inhibitory, right? A2, so it inhibits the release of norepinephrine. So the negative feedback of NE also goes to A2, just A2. and gives you negative feedback. Then you have amphetamines, use the any transporters or NET, that's this thing, uh, to enter the presynaptic terminal. So this would be the presynaptic terminal. This would be the postsynaptic terminal, or here you postsynaptic membrane. So amphetamines use the NE transporters or NET to enter the presynaptic terminals, where they utilize the vesicular monoamine transporter or VMAT to enter neurosecretory vesicles. This displaces norepinephrine from the vesicles. Okay, so it comes in, and then this makes the norepinephrine. What does it do? That it displaces it from the vesicles, so amphetamines can use it, right? So amphetamines and this causes release of norepinephrine, I guess. So then it can use itself to get into those vesicles. Okay. Once NE reaches a concentration threshold within the presynaptic terminal, right here you have enough NE, what happens? The action of NET is reversed. Then the NET is gonna reverse, and NE is expelled into the synaptic cleft, contributing to the characteristics and effects of increased NE observed in patients taking amphetamines. Okay. So this was noradrenergic, and now we have cholinergic. Cholinergics are the ones that use acetylcholine. Right? So choline comes in here, choline plus acetylcholine with choline something transaminase or something like that, I guess. Acetylcholine goes into this, and then it gets released. So calcium, when that comes in, it activates the release of acetylcholine into the synaptic cleft, and then you have botulinum toxin cleaving the snare proteins on top of the vesicles, which help it bind to the surface and leak out the acetylcholine. So you have that in the scenario. You have choline, and then you have acetate, and then you have acetylcholine esterase inhibitors here attaching to the acetylcholine esterases. So when that happens, you have more acetylcholine in the presynaptic cleft, because one way to get rid of acetylcholine is having acetylcholine esterases act on it, right? So you have acetylcholine receptor right there. Okay. Here you have tyrosine coming in. Tyrosine. Remember this from biochem? We did it. So tyrosine comes in to make dopa. Dopa makes dopamine. Then you have VMAT. That was your vesicular monoamine transporter. Having this. This is where risperin or that inhibit the VMAT, right? And then you have NE come in, and calcium then activates the release of NE into the synaptic cleft, and then you have NE go into the diffusion or metabolism, and then you have adrenal receptors, which are alpha and beta. You can have a negative feedback to stop the release, or you can have reuptake of it, because amphetamine, what does it do again? Oh, 10 minutes left. Okay. Yeah, just remember this diagram. But we will probably revisit this a few more times in different chapters. So release of modulating receptors, angiotensin 2 activates the release of this as well. And cocaine, TCA, and amphetamines inhibit NET, so reuptake of this. That's why you get more norepinephrine in the system, and that will give you symptoms. Okay. Then you have cholinomimetic agents. Okay, so cholinomimetics. Watch for exacerbation of COPD asthma, and peptic ulcers in susceptible patients. Uh, let's do this after the break, actually. Agents. Cholinomimetic agents. Okay. So, watch for exacerbation of COPD, asthma or asthma, and peptic ulcers in susceptible patients. Drug action applications. Direct agonists. Bethanol. Give Bethacol. Remember? Where we go? Our mnemonic for this was give Bethacol to unclog the pipes. So you use it in urinary retention. So it activates bladder smooth muscles. So it's resistant to acetylcholinesterases. Uh, it acts on muscarinic receptors, so no nicotinic activity. Give Bethany call me to activate your bladder. I guess that works too, but I'm committed to my mnemonic. And it's used for urinary retention. And then we have carbachol. This is a carbon copy of acetylcholine, right? So col is choline, so carbon copy of acetylcholine. But it's also resistant to acetylcholine. So yeah, similar to this, right? Because remember how what they do, right? Acetylcholine breaks down the acetylcholine. Esterases break down cholinesterase. Acetylcholinesterases break down cholinesterase. Okay, no, acetylcholine. Sorry, it's like a tongue twister. Again, I just had my lunch, so bear with me. Constricts pupil and relieves intraocular pressure in open-angle glaucoma. Right, so constricts pupil, so you have miosis, and relieves intraocular pressure in open-angle glaucoma. That's what you use this for. Then you have methacholine. This is the one that we do for asthma. So it stimulates muscarinic receptor in airway when inhaled. Challenge test for diagnosis of asthma. So know this one and what it does. It stimulates muscarinic receptors in airway when inhaled. Right, and that's how you know if you have asthma or not, because yeah. And pilocarpine, so it contracts ciliary muscles of eye, open angle glaucoma, and pupillary sphincter, so used in closed angle glaucoma. It's resistant to acetylcholinesterases, and it can cross blood-brain barrier. You can drool, you can cry, you can drool, and sweat on your pillow. So, pilocarpine. Potent stimulator of sweat, tears, and saliva. Open angle and closed angle glaucoma or Sjogren's syndrome, xerostomia. Right, so because xerostomia or Sjogren is just dryness of all of these things, right? Your mouth is dry, your eye is dry. So then you can use this for that. Okay, so these were direct agonists. And direct agonists are just drugs that act directly on acetylcholine receptors. Okay, so since they mimic what acetylcholine does, it's called cholinomimetic agents or cholinomimetic agents. Okay, and then we have indirect agonists. These are the anticholinesterases. Right. So then we have donepezil, rivastigmine, and galantamine. They all increase acetylcholine. This Don Riva forgot the gala. So first line for Alzheimer's disease. So you have to remember it for that. Then you have itrophonium. We do this test to figure out if it's like myasthenia gravis or it's the crisis. I forget. Cholinesterase crisis. Right. So this one not cholinesterase. I forget what, but okay. So idrophonium, increase in acetylcholine, historically used to diagnose myasthenia gravis, uh, replaced by anti-ACH receptor antibodies. So anti-acetylcholine receptor antibody test. Let me just look into this. Okay. So we have this way. See idrophonium. Works by prolonging the action of acetylcholine, okay, which is found naturally in the body. It does this by inhibiting the action of enzyme acetylcholinesterase. Acetylcholine stimulates nicotinic and muscarinic receptors. When stimulated, these receptors have a range of effects. Idrophonium is a rapid-acting acetylcholinesterase drug of short duration that improves symptoms of myasthenia gravis by inhibiting the breakdown of acetylcholine and increasing its concentration in the neuromuscular junction. Yeah. Okay, so basically, we do this to make sure that it's not that we don't have the acetylcholine. So this one will inhibit the acetylcholinesterases, right? So then, if the symptoms improve, then it's not myasthenia gravis. But then if it doesn't, then it is myasthenia gravis because you have antibodies against the receptors itself. So even if you have acetylcholine, it's not going to improve. Okay. Neostigmine, increase in acetylcholine again. Neo for CNS and no CNS penetration due to positive charge. Postoperative and neurogenic ileus and urinary retention, myasthenia gravis, reversal of neuromuscular junction blockade, postoperative. Pyridostigmine, increase in acetylcholine, increase in muscle strength, does not penetrate CNS. Pyridostigmine gets rid of myasthenia gravis. Okay, so myasthenia gravis, which is long acting, used with glycopyrrolate, hyoscyamide, and propanthyline to control pyridostigmine adverse effects. Okay. Then you have physostigmine. So basically, acetylcholine, I guess it competitively binds to the receptor along with this. So like it's in like competitive inhibition happens there for the receptors along with the antibodies. I guess that's what it is. Physostigmine, increase in acetylcholine, freely crosses blood-brain barrier as not charged, so it leads to CNS symptoms. Antidote for anticholinergic toxicity. Physostigmine atropine overdose. So this is important antidote. You use physostigmine for atropine overdose. Okay. Okay. So these are the indirect agonists. So they all basically potentiate the effect of acetylcholine, the direct and indirect. It's just that direct acts directly on the receptors, and indirect ones do it by preventing the breakdown of acetylcholine. So it acts on acetylcholinesterases. And say you have anticholinesterases poisoning, which is often due to organophosphates, or for example parathione, that irreversibly inhibits acetylcholine. esterases. Organophosphates commonly used as insecticides or poisoning usually seen in farmers. You get muscarinic effects. Muscarinic effects, this is important. You need to know the dumbbells. So dumbbells are diarrhea, urination, meiosis, bronchospasm, bradycardia, emesis, lacrimation, sweating, and salivation. So you're gonna get fluid secreting from everywhere. So you have diarrhea, urination, meiosis. Meiosis is, you know, the parasympathetic one. So bronchospasm again, bradycardia. These are all your parasympathetic actions, right? Emesis, lacrimation, sweating, and salivation. It's reversed by atropine, a competitive inhibitor, and atropine can cross blood-brain barrier to relieve CNS symptoms. Then you have nicotinic effects, which are neuromuscular blockade mechanisms similar to succinylcholine. The analgesic, I guess. Reversed by pralidoxime, regenerates acetylcholine esterases via dephosphorylation if given early. Pralidoxime oxime does not readily cross blood-brain barrier. So know that, because anything that reverses the neuromuscular blockade is important, right? So it's reversed by pralidoxime. Then you have CNS effects caused by anticholinesterase poisoning, which is respiratory depression, lethargy, seizures, and coma. So in the poisoning, you give atropine, or you can give oximes like pralidoximes. Okay, and the symptoms you're going to see are dumbbells. Again, diarrhea, urination, meiosis, bronchospasm, bradycardia, emesis, lacrimation, sweating, and salivation. We have direct agonists, that was bethanol. Give bethanol to unclog the pipes. Then carbachol. You have methacholine for asthma, and then you have pilocarpine. All of these are direct agonists. The indirect ones are donepezil, rivastigmine, or galantamine, or don't river forgot the gala, right? And then you have etrophonium, to diagnose myasthenia gravis, neostigmine, prednistigmine, and then physostigmine. So the stigmines, and then you have etrophonium, galantium, and donepezil as your indirect agonists, which act on which act on cholinesterases, as right, anticholinesterases, right? Okay. Now we're on muscarinic antagonists. So these are your atropine, homatropine, tropicamide, organ system I, produces mydriasis and cycloplasia. They do this to check the eye sometimes. And then you have benztropine, trihexyphenidyl, CNS, Parkinson disease, park my benz, acute dystonia. So we'll come across this in CNS. But yeah, just remember benztropine and trihexyphenidyl. It's used in acute dystonia. Then you have glycopyrrolate, GI and respiratory organs. Pre-operative use to reduce airway secretion, and oral, reduce drooling, peptic ulcer. You have hyoscine and diclomine, GI, antispasmodic for irritable bowel disease. We'll do that in GI too. Ipratropium, tiotropium, this is a respiratory drug for asthma or COPD. Duration is tiotropium has a longer duration than ipratropium. Then you have soft or solifenacin, oxybutynin, or overactive for overactive bladder. Then you have flivoxate and pterodine. Genitourinary bladder, reduce bladder spasms and urge urinary incontinence for overactive bladder. So make bladder soft. Urge urinary incontinence. Right? So it relaxes it. Scopolamine, CNS, motion sickness. You don't have to remember the middle part because that's pointless. But remember the applications, so you'll know that anyways. So scopolamine is known for motion sickness. This is what you take or give. Then you have soft for overactive bladder, the asthma drugs, the antispasmodics for irritable bowel disease (IBS), and then you have glycopyrrolate for airway secretions, and also oral for reducing drooling. You have benz and trihexyphenidyl for acute dystonia and Parkinson's disease, and you have atropine, hometropine, and tropicamide for producing mydriasis or cycloplegia. Okay, so atropine. Atropine is a big drug. You should know about this. It's a muscarinic antagonist, right? It's used to treat bradycardia and for ophthalmic applications. So what this one does is the dumbbells that we saw here, these are the muscarinic effects, right? So then atropine, what's it gonna do? It's a competitive inhibitor, so it's gonna inhibit the muscarinic effects. So all the effects it has are gonna be opposite to this. Okay. So muscarinic antagonists used to treat bradycardia and for ophthalmic applications. Organ systems. Eye. Since muscarinic effect causes meiosis, this one's going to cause mydriasis, right? So it increases pupil dilation and cycloplegia. In airway, you were getting secretions and constrictions, I guess, or not, but secretions, right? So you have bronchodilation. Bronchospasms, yeah. So you have bronchospasms, so it's going to cause bronchodilation. Right. And reduce the secretions. In stomach, you have decreased acid secretion. In gut, you have increase in motility. And then you have bladder decrease in urgency and cystitis. So no, blocks muscarinic effects, dumbbells of anticholinesterases, but not the nicotinic effects. Right? Keep going far. So nicotinic effect was this neuromuscular blockade. For that, you need to give auxin. But all of these are done by atropine, blocked by it. Okay, so adverse effect, what were you gonna have? Increase in body temperature, so hot as a hair, due to decrease in sweating. Then you have increase in heart rate, so fast as a fiddle, dry mouth, and dry flushed skin, so dry as a bone and red as a beet. And then you have cycloplegia, so blind as a bat, and constipation. And then you have disorientation, so mad as a hatter. And then it can cause acute angle closure glaucoma in older patients due to mydriasis. Urinary retention in men with prostatic hyperplasia, and hyperthermia in infants, so full as a flank. So you have hot as a hare, fast as a fiddle, dry as a bone, red as a bee, blind as a bat, mad as a hatter, and full as a flask. Jimson weed or datura, Gardner's pupil, mydriasis. Okay, so they do ask about this, and they give you that this is what the person had or came in contact with, and what kind of effects are you going to see. So then you have to remember these adverse effects. Also that it is similar to atropine. Okay, so now you have sympathomimetics, the fight or flight responses. Uh, Direct sympathomimetics. Uh, Let me bring that one out again. Remember. Okay, so now we have direct sympathomimetics. So albuterol, salmeterol, and terbutaline. So beta 2, it acts on beta 2 more than beta 1. There's increase in heart rate, so a little effect, because they both act on hearts, right? This has a non-selective one, and this is heart selective, but this does have a little heart act on the heart. This one acts on the heart and the renin system. So increase in heart rate, little effect. Application albuterol for acute asthma and COPD. Salmeterol for serial long-term asthma COPD. Terbutaline for acute bronchospasm in asthma and tocolysis. We'll do this and respi as well, but yeah. So these are direct sympathomimetics again. You have dobutamine. It has a beta 1 action more than beta 2 and alpha. So it can be nothing, or it can decrease blood pressure, increase in heart rate, increase in cardiac output. So this is what you give to, increase cardiac output. So cardiac stress testing, acute decompensated heart failure with cardiogenic shock, inotropes. Then you have dopamine. D1 is equal to D2, which is more than beta and alpha action. Right? So you have increase in BP. Remember, D1 was excitatory and then D2 was inhibitory, but it's equal here, like equal potency, I guess that's what it means. Right. But this one is more potent than on this. Dopamine is more efficacy. That's what it's about. Okay, my bad for that. Increase in BP high dose, increase in heart rate, and increase in cardiac output. Unstable bradycardia, shock, inotropic, and choreotropic effect at lower doses via beta effects. Vasoconstriction at high doses via alpha effects. So this is the most important one out of this whole page, I think, because this is the one that they test you on. That in lower doses, it has a beta effect, right? So beta effect was beta 1 and beta 2, beta 3. And then on higher, you have alpha effect, which was vasoconstriction, remember? So if you don't remember, we'll do that. So contraction for that, and then for beta you have vasodilation, right? So this one does vascular contraction, this one does vasodilation. So that's what it is about. So again, at lower doses it does vasodilation effects on stuff, and then on higher doses it will do vasoconstriction. Then you have epinephrine, beta and more than alpha, right? So that uses the S system, and alpha is the Q and I. It increases BP high doses, increase in heart rate, and increase in cardiac output as well. Anaphylaxis, asthma, shock, open angle glaucoma, Alpha effects predominate at higher doses, stronger effect at beta 2 receptors than norepinephrine. Then you have phenyledopam, D1, decrease in BP, vasodilation, increase in heart rate, increase in cardiac output, post-operative hypertension, hypertensive crisis, vasodilator, coronary, peripheral, renal, and splenic, promotes natriuresis, can cause hypotension, tachycardia, flushing, and headache. Then you have isoproterenol, beta 1, and it's equally on beta 1, acts equally on beta 1 and beta 2. Decrease in BP, vasodilation, increase in heart rate, and increase in cardiac output, because beta does vasodilation, remember, but it does increase heart rate and contractility. Electrophysiologic evaluation of tachyarrhythmia can worsen ischemia, has negligible alpha effect. Then you have midodrine, which is completely alpha 1, so vasoconstriction, so increase in BP, but decrease in heart rate and decrease in cardiac output. Autonomic, why? Because since it's vasoconstriction, the venous return is also decreased, right? So if it doesn't come in much, then it's not going to go out much. Also, this decrease. So autonomic insufficiency and postural hypotension may exacerbate spine hypertension. Then you have Mirabic grown, or me bladder has grown, so it relaxes, increases the capacity of the bladder, B3. So it's used for urinary urgency or incontinence or overactive bladder. Think Mira B3 grown. Then you have norepinephrine, alpha 1, alpha 2, and beta 1. So acts on alpha 1 more than it does on alpha 2, which is more than on beta 1. Increase in BP, it can stay the same or decrease in heart rate, may have minor reflexes. Change in response to increase in BP due to alpha 1 agonism outweighing direct beta 1 chronotropic effects. So cardiac output can stay the same or increase because of that. So reflecting change in response to increase in BP due to alpha 1 agonism outweighing the direct beta 1 chronotropic effect. Okay. So hypertension and septic shock. And then you have phenylephrine, alpha 1 and more than alpha 2. So vasoconstriction, increase in BP, decrease in heart rate, and decrease in cardiac output. So remember, alpha 1 is all about calcium, and alpha 2 is inhibitory, so it inhibits this stuff. Hypertension, vasoconstrictor, ocular procedure, mydriatic, rhinitis, decongestant, and ischemic or priapism. Okay, and then we have indirect sympathomimetics, which are amphetamines. Right, so since it's sympathomimetic, remember it was fight or flight, so you're going to have increase in heart rate. Increase in heart rate everywhere, except for these, because it causes increase in BP instead of heart rate. So like even if you're like sitting and worrying, you're going to get increased in BP because of this. So it's still sympathomimetic. Then you have indirect sympathomimetic, amphetamine, indirect general agonist, reuptake inhibitor, also releases stored catecholamines. So narcolepsy, right? So that's when the person suddenly falls asleep on the spot. They can fall as well. Obesity, and then you have ADHD. It kind of seems like it doesn't go, but you give stimulants in ADHD, so we give amphetamines for that. Um, Stimulants for that. Okay, so now we have cocaine. Uh, Indirect general agonist reuptake inhibitor causes vasoconstriction and local anesthesia. Caution when giving beta blockers if cocaine intoxication is suspected. Unopposed alpha 1 activation and a lot of increase in BP and coronary vasospasm. Right? So it causes mydriasis in eye with intact sympathetic intervention used to confirm Horner syndrome. Right? Okay, so again, this one cocaine, it has a alpha action, right? That's what it's saying. So it's a indirect general agonist reuptake inhibitor. So it causes vasoconstriction and local anesthesia, right? So when cocaine is sniffed, because why not? Since we're doing it. Okay, so when a person sniffs it with a roll or something through the nose, the particles there are going to cause vasoconstriction, right? So the only thing that's preventing it from going haywire or even maintaining the balance are the beta 2 or beta 1 or beta 2, right? Yeah, beta 2, sorry. Because beta 2 action causes vasodilation, right? Remember, again, beta 2 causes vasodilation. So when you give beta blockers, what's going to happen? When you give beta blocker on top of cocaine, there's nothing opposing the vasoconstriction anymore. So you're going to have ischemia. You're going to end up with ischemia there, right? And this is why long-term use of cocaine, even with normal beta function, people start having due to the ischemia when they do a lot, right? They start having perforations in the septum, in the nose. Okay, so when you give beta blockers, there will be unopposed alpha activation, so increase in BP and coronary vasospasm as well. But yeah, ephedrine, indirect general agonist, releases stored catecholamines. Nasal decongestant, so pseudoephedrine, urinary incontinence, and hypertension. Remember what I told you about cocaine, and then also remember that we give a stimulant in ADHD. Okay, and it's also used for narcolepsy. Okay, we're on physiologic effects of sympathomimetics. Let's see if I have any notes on this. So I have mydriasis, pupillary dilation of eye. Then commonly used drugs are tropinamide, cyclopentolate, hometropine, atropine, and scopolamine. Anticholinergics restore dopamine. Okay, so anticholinergics restore dopamine. So you have anticholinergic restore dopamine to acetylcholine balance. Since there is relative increase in excess of acetylcholine when dopamine is depleted, right? So when you give anticholinergics, it'll be a relative restoration of the ratio or the balance. Benztropine and trihexyphenidyl. These are your anticholinergics. Okay. Atropine is used in bradycardia and OP poisoning. Scopolamine blocks the M1 receptor. So that was scopolamine blocks M1 receptor, there are other antihistaminics like meclizine and dimenhydramine, something like that. We'll figure it out. Okay, anticholinergic toxidrome. Oh yeah, you need to know about the anticholinergic toxidrome. That is muscarinic blockade. So these are the drugs that we talked about: antihistaminic, antihistamine, tricyclic antidepressants, atropine, and plant is Jimson weed datura. So know this terminology: toxidrome. It's the muscarinic blockade. Okay. So for this, I watched Dirty Medicine, and what he said helps a lot. So rather than memorizing everything, just memorize the pattern, and that's the way he taught us to do it. So physiologic effect of sympathomimetics. Norepinephrine increases systolic and diastolic pressures as a result of alpha 1 mediated vasoconstriction. So there is increase in mean arterial pressure, which leads to reflex bradycardia. However, isoproterenol, rarely used, has little alpha effect but causes beta 2 mediated vasodilation, resulting in decrease in mean arterial pressure and increase in heart rate through beta 1 and reflex activity. Okay. So, however, isoproterenol rarely used has little alpha effect but causes B2 mediated vasodilation, resulting in decrease in mean arterial pressure and increase in heart rate through beta 1 and reflex activity. Okay. So we have norepinephrine, epinephrine, and isoproterenol. The questions will have some kind of chart like this, and they'll ask you what kind of drug was used on this, right? So that's basically what it is. So let's see. For Nor, you write it like Nor, but you write like Nor when you're writing it. So that's because it has an alpha action, and it's important to remember that it has a alpha action more than the beta one, so it causes vasoconstriction more than the vasodilation. Then you have epinephrine. So when you write epi, you think of it like ebi, e beta I. You write right. That's a beta, not a b. But yeah, instead of epi, you do it b because it has a more predominant beta effect than alpha, so it will vasodilation more than the alpha one. Right? And then you have isoproterenol, and then for that, isopro. Instead of that, you'd say isobro. So that's a beta as well. Okay. So here we have systolic pressure, and we have diastolic pressure, and then we have mean arterial pressure. Right? Mean arterial pressure is what was it? Systolic plus 2 diastolic divided by 3, I think. Right. Yeah, so systolic plus 2 diastolic divided by 3. So that's your mean arterial pressure. Okay. So notice how in NOR it goes up, then goes, and then it comes down, right? So it goes up and down like that. So when you write it, you do N, and then your N would look something like this, right? So it goes up and down, and that's how you remember that. For the E, similarly, you just draw the way it looks, and it looks like an E. So it's up, and the middle one is also up, and the bottom one is down. So up and down. And then for isopro, I don't remember what he said for this one. I guess it's the same. So it's up like that and it's like that. We'll come to that. So let's try to understand what this is, right? But just keep in mind, if nothing else works, just try to remember what it looks like. So it has an increase in alpha action. So you're gonna have vasoconstriction. When you have vasoconstriction, your BP goes up, right? When your BP goes up, what happens to the resistance? The resistance increases massively, right? Compared to your normal one. So your peripheral resistance is increased, right? Unopposed. And your systolic pressure is also increased because it has to work harder to come out, right? And then your blood pressure is like diastolic is also, it's gonna stay the same almost, right? It's gonna stay at the line, but the systolic is increased definitely. So they both increase a little. Diastolic not so much as systolic. So I guess this is the normal one. And then the mean arterial pressure, this is what you have in the middle. Okay, and then the heart rate, because of reflex bradycardia, because your brain is obviously going to try to slow it down, it's going to decrease. Then in epinephrine, since it has a more beta action than alpha, uh, what does beta do? It's the in the vessels it's going to cause vasodilation, but in the heart it's going to increase, right? So vasodilation will do what to the resistance? It will decrease it. But in heart rate, what's it going to do? It's going to increase it, right? Because that's what it's known for, the beta actions. Here it's given that it's B2 more than alpha 1, but here it's beta action more than alpha, so I guess we look at that, because it's mentioned here too, right? But that's only for this, okay, so that makes sense as well. So your diastolic is going to be really low, because when you have vasodilation, your venous return kind of decreases, so the filling of the ventricle is going to be low anyways, so diastolic is going to be low, but the systolic is going to increase a little, right? But not as much as this, because it can only pump out as much as is there, so it only lasts for a little longer than normal, but not so much as like this. So epinephrine is that. I'm done with that. Isoproterenol, beta 1 and beta 2 equally. So beta 2 is going to vasodilate. So again, this time it doesn't even have the opposing alpha action. So it's just going to vasodilate the most. So unopposed beta 2 action. Then you have beta 1, which increases the heart rate. So beta 1, and you have reflex tachycardia because of this vasodilation, right? So when you have vasodilation, the signals go to the brain that we need to fill these veins up with more blood. So that what's it going to do? It's going to pump more blood, and that's why you get reflex tachycardia. So your systolic is going to increase a little, but your diastolic is going to go really low because, again, vasodilation, right? So venous return is lower, so filling is going to be lower too. So diastolic is going to be less. Sorry. Then you have systolic as well. It's going to be increased just as much as this because alpha, anyways, doesn't have any effect on heart rate. So it's going to be similar to this. But since this one is lower, so when you add these two up, the mean arterial pressure is going to be lower. Okay. So for this, cardiac output is increased, heart rate is increased, but mean arterial pressure is decreased, and peripheral resistance pulse pressure is increased, right? Then in cardiac output is increased in epinephrine, heart rate is increased, mean arterial pressure is increased, and pulse pressure is increased. In norepinephrine, cardiac output is the same because of reflex. Then you have heart rate decrease again because of reflex. And then you have mean arterial pressure, because when you have this, just like this one, the signals go and tell the brain that you need to slow down, right? So that's why you have reflex bradycardia and heart rate is decreased. Mean arterial pressure is going to be increased and pulse pressure is increased as well. Okay, but if you just remember this pattern, these two are going up, and in N everything's going up and then down. In epinephrine, the two lines on the top go up and then one line at the bottom go down. And then for isoproterenol, it's almost equal, but the mean arterial pressure is slightly downwards. Okay. Epinephrine before alpha blockade and after alpha blockade. So you have blood pressure, and you have epinephrine is this one. There, it goes up, and then down. So it has a predominantly EBI, right? So that's beta 2 or beta action. So heart rate is increased because of beta 1 action. Sorry. And then you give a alpha 1 alpha blockade. So what's going to happen? It doesn't have any effect on the heart, right? So heart rate's going to remain the same. But what does it have an effect on the vessels? So when vessels start to constrict, vasoconstrict, then what's going to happen? It's going to send a signal to the brain to tell them to slow down. So that's going to cause the slowing down of the thing. So you get reflex tachycardia. I thought it was Brady. There's unopposed beta 2 action. Okay. Oh, here. But then after alpha 1 blockade. Oh, wait. You're not giving alpha 1, you're blocking alpha 1. My bad. Right. So I got that backwards. It's a blockade. So you're blocking alpha receptors. So when you block alpha 1 is known for vasoconstriction. So if it has predominant beta, and then you don't even have alpha 1 to balance it out, it's going to vasodilate to the max. So what's brain going to it's going to send a signal to the brain that, hey, vessels are empty, it's vasodilated, fill them up. So then you get reflex tachycardia because brain is going to send signal to pump out more blood. So that's why you get reflex tachycardia. Okay, makes sense. Unopposed beta 2, net depressor effect, and then this. Okay. And then you have phenylephrine after alpha blockade. Okay. And after. Okay, so this is before alpha blockade and this is after alpha blockade. I'm having a hard time reading this. Okay, so systolic, diastolic, the alpha 1 blockade is gonna. Yeah, I need the break. So pressure effect, uh, that. Alright, so phenylephrine response is suppressed but not reversed because it is a pure alpha agonist. It lacks the beta agonist properties. That's why. So you have reflex bradycardia because what's it gonna do? Uh, Phenylephrine, it has an alpha action, right? Alpha 1 and alpha 2. So it's gonna do vasoconstriction without opposition. So when it does that, the brain is gonna send signal to do slow down, so you get reflex bradycardia. But then when you block alpha receptors, what's it gonna do? It's not that beta is gonna start doing more things, because it wasn't having any effect on that to begin with. So the only thing that's gonna happen, your systolic is gonna drop. That's it. So everything else comes down as well, and uh, the heart rate will, you know, normalize a little. Then you have sympatholytics. These are your alpha 2 agonists. So remember what your alpha 2s do? It's inhibitor ones, so it decreases everything or inhibits the release of everything, and also, you know, increases platelet aggregation or yeah. Okay. Okay. So A2 agonist. So it's gonna help potentiate the effects of alpha 2 receptors. So clonidine and guanfacine. This is hypertensive urgency, unlimited situation, ADHD, Tourette's syndrome, symptom control, and opioid withdrawal. Then you have, yeah. For this, I had a mnemonic too. I'll just write that. So 2 alphas gone facing clone for dealing with 2 Tarzan. Okay, so Tarzan is your Tarzan, and then meth is methyl-dopa. Guanfacine is guanfacine, and clone is for this, for dealing meth, methyl-dopa 2 Tarzan. It doesn't make sense, but if you remember any of these, the other ones come to mind as well. So this is I have a whole story in my head for this, but I'm not going to go over it because this might not help you guys. It's just for me. Sympatholytics, alpha 2 agonists, drug application adverse effects, clonidine and guanfacine. So these are used for hypertensive urgencies, right? Because they decrease everything, right? So limited situation. And it inhibits the secretion of everything too. So ADHD, Tourette's, symptom control, and opioid withdrawal. Adverse effects are seen as depression, bradycardia, hypotension, respiratory depression, meiosis, rebound hypertension with abrupt cessation. Alpha methyl-dopa, it's used in hypertension and pregnancy. Direct Coombs, positive hemolysis, drug-induced lupus and hyperprolactinemia can happen if you use this drug, like the adverse effect of it. And then you had tizanidine, relief of spasticity, hypotension, weakness, and xerostomia. Instead of side effects, just remember that these are alpha 2 agonists and what alpha 2 agonists do. And that's more important. What's important is alpha methyl-dopa is used in hypertension in pregnancy. Okay, and yeah, just remember these drugs are for alpha 2 alpha blockers now. We learned about alpha 2 agonists. Now we're going to learn about the blockers. So drugs application adverse effects. Non-selective. These are phenoxybenzamide and phentylamine. Right. The way I remember it is like alpha is like alpha males. Right. So I'm thinking of this as like Batman and Robin. That's how I remember these two. Just looking at them, I remember that this is the Batman one and this is the Robin one. Why? I don't know. It makes no sense. But so what do? They block the alpha, right? Alpha males are usually like dicks, and then Batman takes care of them. So kind of like that. So it's non-selective. It doesn't discriminate who it is. They just go after it. It's very silly. I know. I get it, but it works. Okay, so yeah, phenoxybenzamine, irreversible pheochromocytoma used preoperatively uh, to prevent catecholamine hypertensive crisis. And then you have phendylamine, which is reversible, given to patients on MAO inhibitors who eat tyramine containing foods and for severe cocaine induced hypertension. Uh, this is second line. Also used to treat norepinephrine extravasation. So adverse effect is orthostatic hypotension and reflex tachycardia. Okay. We have alpha 1 selective. These are the one with osin in it. So prazosin, uh, terazosin, and doxazosin, and tamsulosin. Right. Uh, how do I remember this? I remember how I remember this, but just osin, you can think of it like asin, because there's. Oh right, yeah. So this is an actress. Yes, it's asin or something like that in India. And so osin, asin. That's how I remember it, and A for alpha 1 selective. Okay. Now, urinary symptoms of BPH. Uh, so, what does this do? It causes contraction, right? So, contraction of the sphincters and bladder will cause, uh, will disinhibit the obstruction, right? So, urinary symptoms of BPH, and then you have PTSD, prazosin, and hypertension, except for tamsulosin. First dose of orthostatic First dose orthostatic hypotension, dizziness, and headache. That's what you get from the first dose. Okay. And then you have alpha 2 selective. This is mirtazapine, uh, depression, sedation, increase in serum cholesterol, and increase in appetite. So alpha 2 does what? It decreases everything, right? So it's going to decrease the hormones that cause depression, and then it's going to cause sedation as well, and there will be increase in serum cholesterol because this causes decrease in it decreases lipolysis, right? So wait, what does alpha 2 do to increases lipolysis, right? I was thinking of no, wait, this one, yeah. So it decreases lipolysis, alpha 2. But okay. So it increases serum cholesterol, and then it increases appetite. know these drugs, but at least what they do and what class they are. So this is alpha 2 selective, this is alpha 1 selective, this is non selective alpha blockers. Then you have beta blockers. So these are your acebutolol, etanolol, betoxazole, bisoprolol. There's a thing for this too. Okay. Sorry. So you have any of the beta blockers that start with A to M is going to be beta 1 selective, and then uh, non selective are the N to Z. Okay, so cardio selective ones are is to metoprolol, and everything after that is going to be your non selective ones. Okay, so cardicolol, esmolol, labetalol, metoprolol, nadolol, nebuvolol, pindolol, and propranolol, and timolol. Application, action, and notes and examples. Okay. Angina pectoris. For that, you give it so its action is it decreases heart rate, contractility, which decreases the O2 consumption. Um, so less ischemia causes less pain. Glaucoma, decreased production of aqueous humor, so timolol. For example, heart failure, blockade of non-hormonal stress, neurohormonal stress, so it leads to prevention of deleterious cardiac remodeling, which causes decrease in mortality. So this is bisoprolol, carvedilol, and metoprolol. So beta blockers curb mortality. Hypertension is decrease in cardiac output, decrease in it causes decrease in renin secretion due to beta 1 receptor blockade on juxtaglomerular cells. Then you have hyperthyroidism and thyroid storm. So symptom control, decrease in heart rate, decrease in tremor, propranolol. Hypertrophic cardiomyopathy, decrease in heart rate, increase in filling time, revealing obstruction. Myocardial infarction, decrease in O2 demand short term, decrease in mortality for long term. In supraventricular tachycardia, beta blockers can decrease AV conduction velocity, class 2 antiarrhythmic, for example, metoprolol and esmolol, and variceal bleeding. So decrease in hepatic venous pressure gradient and portal hypertension. Prophylactic use, nadolol and propranolol, carvedilol. Then you have adverse effects, uh, which is erectile dysfunction, cardiovascular, for bradycardia, AV block, and heart failure. Then you have CNS, like seizures and sleep alterations, and then you have dyslipidemia. Metoprolol, for example, will cause that. MAST, hypoglycemia, asthma, asthma, and or COPD exacerbations. So use of beta blockers for acute cocaine-associated chest pain remains controversial due to unsubsustained concerns of unopposed alpha-adrenergic stimulations. Okay, it's just saying what we talked about in cocaine-associated chest pain. Then selective beta 1 selective antagonists, beta 1 more than beta 2, S-butalol, partial agonist atenolol, betaxazole, bisoprolol, esmolol, and metoprolol. So selective agonists mostly go from A to M. So beta 1 with first half of the alphabet. Non-selective antagonists, B1 equals B2, nadolol, penodolol, partial agonists, propranolol and timolol. Non-selective antagonists mostly go from N to Z. So B2 with second half of alphabet. Non-selective alpha and beta antagonists, carvedilol and labetalol. So non-selective alpha and beta antagonists have modified suffixes instead of olol. They have ilol and alol. And then you have nebivolol, combines cardioselective beta-1 adrenergic blockade with stimulation of beta-3 receptors, which activates NO synthase in the vascular and decrease systemic vascular resistance. So nebivolol increases NO. How that works is this thing right here, through guanylate cyclase, converts GTP to cGMP and causes PKG. Right? So that's how nebivolol increases NO. Phosphodiesterase inhibitor. So that's phosphodiesterase PDE inhibitor inhibits the PDE, which catalyzes the hydrolysis of CAMP and or cGMP, and thereby increases cGMP and or cGMP. Right, so it's talking about this right here. CMP, and cGMP right here. Okay. Specificity of okay, so type of inhibitors. So there is non-specific PDE inhibitors. So that's theophylline. It decreases CAMP hydrolysis, so increases CAMP. So it decreases the breakdown of CAMP. So there is increase in CAMP, and then you have bronchial smooth muscle relaxation, right, which will cause bronchodilation. It's used in COPD and asthma. It's rarely used in asthma. Okay. Adverse effect is cardiotoxicity, for example, tachycardia, arrhythmia, neurotoxicity, for example, seizures, headache, abdominal pain. We'll come to this again in RESPI. PDE5 inhibitors, sildenafil, verdenafil, tadalafil, and evenafil. So all the fils. It decreases the hydrolysis of cGMP, so breakdown of cGMP doesn't happen. So there will be increase in cGMP, which leads to increase in smooth muscle relaxation by enhancing NO activity, right? It increases NO activity, so NO is known for vasodilation. So you'll get pulmonary vasodilation and increase in blood flow in corpus cavernosum fills the penis. Okay. Erectile dysfunction, it's used for that. Pulmonary hypertension and benign prostatic hyperplasia, tadalafil or tadalafil only. Adverse effects is facial flushing, headache, dyspepsia, hypertension in patients taking nitrates, hot and sweaty, then headache, heartburn, hypotension, sildenafil only. Synopia, blue tinted visions, while inhibition of PDE6 in retina. Okay. So sildenafil is an important one. We'll come to that too, but it's important because of this. It's a PDE5 inhibitor, and if you have this, you know those ads you get, like if you have taken this and it's been going on for longer than like 4 hours, you should contact doctor. It's because it happens when there is muscle relaxation, right? So when you have overdone this, then there are chances that you're going ischemic, something like that. We'll do that when it comes. Then you have PDE4 inhibitor, that's roflumilast, increase in camp and neutrophils, granulocytes, and bronchial epithelium, severe COPD, abdominal pain, weight loss, depression, anxiety, insomnia. PDE3 inhibitor is milrinone, that's in cardiomyocytes, increases camp again, increases calcium influx, so it has a inotropic activity and chorotropic activity. In vascular, smooth muscle, again myosin light chain kinase inhibition, vasodilation, which leads to decrease in preload and afterload, acute decompensated heart failure with cardiogenic shock, inotropes. Uh, you get tachycardia, ventricular arrhythmias, and hypertension with this as side effects. And then you have platelet inhibitors, cilostazol and dipyridamole. In platelets, it increases camp again, inhibition of platelet aggregation. Intermittent claudation, stroke of TIA prevention with aspirin. Cardiac stress testing, so dipyridamole only due to coronary vasodilation. Prevention of coronary stent and restenosis. Nausea, headache, facial flushing, hypertension, and abdominal pain. Okay. You need to know about what you need to know about these is their mechanism of action mostly, right? Because the clinical uses will do it in like respi and heart and all that stuff where it comes, but at least know the mechanism of action because that's not going to be explained in the respective chapters. Cilostazol is a PDE3 inhibitor, but due to its indications is categorized as a platelet inhibitor together with dipyridamole. Okay, so this thing is actually under here, but since it is a platelet inhibitor, it's characterized with dipyridamole. Okay, dipyridamole is a non-specific PDE inhibitor leading to inhibition of platelet aggregation. It also prevents adenosine reuptake by platelets. It leads to increase in extracellular adenosine, and it leads to vasodilation, increase in vasodilation. Pharmacology, toxicities, and adverse effects. They test you on all three of these. Okay, so ingested seafood toxins action includes. Toxin actions include histamine release, total block of sodium channels, or opening of sodium channels to cause depolarization. Or opening of sodium channels to cause depolarization, right? Okay, so it will either block sodium or it will open sodium to cause depolarization. That's all. Toxin source action symptoms treatment. Histamine, which is a scombroid poisoning. Where do you get that from? Spoiled dark meat, fish such as tuna, mahi mahi, mackerel, and bonito. If I'm butchering the pronunciation, it's because I'm vegetarian, so I wouldn't know these by itself. Action is bacterial histidine decarboxylase converts histidine to histamine, frequently misdiagnosed as fish allergy. Right. Then you have symptoms, which are mimics, anaphylaxis, oral burning sensation, facial flushing, erythema, urticaria, itching, may progress to bronchospasm, angioedema, and hypotension. Treatment is antihistamines, albuterol with or without epinephrine. Then you have tetrodotoxin. This is a fun one. You get it from pufferfish. Action is it binds fast voltage gated sodium channels in nerve tissue, preventing depolarization. Symptoms are nausea, diarrhea, paresthesia, weakness, dizziness, loss of reflexes. Treatment is supportive. Then there is ciguatoxin, so that's from reef fish, such as barracuda, snapper, and moray eel. Action is it opens sodium channels, causing depolarization. Symptoms are nausea, vomiting, diarrhea, perioral numbness, reversal of hot and cold sensation, bradycardia, heart block, hypertension. For these, you need to know what the mechanism of action is. So for ciguatoxin, it opens sodium channels, so causes depolarization. Right. For tetrodotoxin, it binds to the voltage-gated sodium channels in nerve tissue, and it prevents depolarization. Right. So D for down in tetrodotoxin. Right. And in ciguatoxin, you have U for up. So uh, increased sodium depolarization. Here is down, action potential or depolarization, right? And then you have histamine, which mimics depolarization, but it's just histidine to histamine, so it frequently misdiagnosed as fish allergy. In tetrodotoxin, you get your paresthesia, weakness, and loss of reflexes. So this is like a tough one to pick out in a question stem, but uh, they might tell you that this person went out to eat in a restaurant that has this, and then the next day, or like not the next day, but like after 5 minutes of having it, he started feeling symptoms of nausea and then paresthesia and weakness, and he had like dizziness, and then but by the time he reached the hospital, he was like paralyzed or something. He can't talk, so it binds fast voltage-gated sodium channels in nerve tissues and prevents depolarization. Right? And in ciguatoxin, similar question stem, but here they'll say that there is a perioral numbness. He's been vomiting. Uh, he can't understand from hot from cold. Then bradycardia, heart block, or hypertension. It's hard to know, but they might even tell you the name of the fish that he was having. So you can figure it out from that as ciguatoxin, which opens up, right? So opens up sodium channels, causing depolarization. Okay. Age-related changes in pharmacokinetics. Aging alters the passage of drugs through the body, and standard doses can result in increased plasma concentrations. Older patients often require reduced doses to prevent toxicity. So in absorption, it's mostly unaffected. Distribution, there is decreased total body weight of water, so there is decrease in volume of distribution of hydrophilic drugs. So there will be an increase in concentration. Increase in total body fat, so there will be increase in volume distribution of lipophilic drugs, the drugs that do like fat instead of air. So this will increase the half-life of those drugs. Metabolism, there's a decreased hepatic mass and blood flow, so there's decreased first pass metabolism, decrease in hepatic clearance. Phase 1 of drug metabolism is decreased. Phase 2 is relatively preserved. Excretion, decrease in renal mass and blood flow, so decrease in GFR and decrease in renal clearance. There's Beers criteria. This one you should know because it's widely used criteria developed to reduce potentially inappropriate prescribing and harmful polypharmacy in the geriatric population. But most of the time, they'll give you all these drugs that are doing things to this old person, and most of the time it's going to be antihistamines that you have to take out of their prescription to stop having the symptoms that they're having. So what do I mean with that? Well, read about it. So it includes more than 50 medications that should be avoided in older patients due to decrease in efficacy and or increase in risk of adverse effects. For example, after block, sorry, alpha blockers increase risk of hypotension, uh, so it should be avoided in older patients. Then there's anticholinergics, antidepressants, antihistamines, and opioids. They increase the risk of delirium, sedation, falls, constipation, and urinary retention. So here, this is the major one that is usually the culprit in a question stem at least. Then you have benzodiazepines increase risk of delirium, sedation, and falls. How you remember it? That Ben likes it more frequent and Barb likes it longer, because Ben increases the frequency of chloride channels, and then Barb increases the duration of the chloride channels. Right, so that. Then you have NSAIDs, increasing risk of GI bleeding, especially with concomitant anticoagulation. PPIs, increased risk of C. difficile infection. Okay. So these are your beer criterias. So it's probably all the drugs you know about at this point that should be avoided in adults, or I mean older patients. Okay, because of these risks. But normally they'll be like, okay, so their mother or grandmothers, they're forgetting to take their medicines, or they're forgetting the way to their house or something, and they had like recent falls, right? So after changing medications, or like seasonal medications, or like for antihistamines or something like that. Okay. Specific toxicity treatments. Toxins acetaminophen, and treatment is N-acetylcysteine. So it replenishes glutathione. This is the mechanism of action. You should know this one definitely. Acetylcholinesterase inhibitors, organophosphates. We did this. Atropine, and then you have prelidoxine for nicotinic, and then for muscarinic. Right. So anti-muscarinic, anticholinergic agents. Physostigmine, because it crosses BBB and controls hypothermia. Arsenic, you give dimercaprol and succimer. Succimer is going to come like 2-3 more times. Benzodiazepine, flumazenil, and then you have beta blockers, atropine, glucagon, and saline or saline. Carbon monoxide, 100% O2, hyperbaric oxygen. Copper, penicillamine, trantine. Okay. Cyanide, hydroxycobalamin, nitrites, plus sodium thiosulfate. This is an important one to know. You should actually know about all of these, because this is like the high yield ones anyways. So dabigatran, that's idarucizumab. Then you have digoxin, that's digoxin specific antibody fragments. Then you have direct factor 10A inhibitor, for example epixaban, that's adixonate alpha. Then there's heparin, for that you have protamine sulfate. Don't confuse this with the one for warfarin. For warfarin, you just give the vitamin K, or you can give PCC and FPP. I mean FFP, sorry. But yeah, so heparin, protamine sulfate is important to remember, because that will be asked in Pharmacy General or in EMAT. Iron, this one's easy to remember because it has Fe in all its names. So deferoxamine, deferoxamine, deferoxyrox, and deferriprone. And then you have lead, calcium, sodium, EDTA, dimercaprol, succimer, penicillamine. You have mercury for dimercaprol or succimer as well. Succimer again, it was for this and this. They both are dimercaprol and succimer. But this one's easier to remember because it has more in it, so mercury. It's used for mercury. Then you have methanol and ethylene glycol antifreeze. Uh, Fomepizole is the one that is more effective because it inhibits the dehydrogenase, alcohol dehydrogenase, or is it aldehyde dehydrogenase? It's one or the other. And then you have ethanol dialysis. Then you have methemoglobin, methylene blue, vitamin C, and reducing agents. This is an important one too, but it's easy to remember. This is for this as well. Yeah, we'll do that. I think him at methotrexate, leucovorin, opioid, naloxone, salicylates. That's sodium bicarbonate. So alkaline urine, alkalinizes the urine, and dialysis. You have tricyclic antidepressants. That's sodium bicarbonate again stabilizes cardiac cell membrane, and then you have warfarin, vitamin K delayed effects, PCC, prothrombin, complex concentrate, and FFP, immediate effect. So there will be a question about this that the person is given too much warfarin or he has too much warfarin. So what should be the first line of action for you as an intern? What should you give? So you'll have all of these in there as an option and then a couple more. So you would probably think vitamin K because that's what this one inhibits. So if you have more, then it's gonna be FFP because this is the one you give for immediate effect. Okay, and then you can give vitamin K after you have done giving this. Drug reaction. That's just fresh frozen plasma. That's what it is, and it contains all the coagulation factors in it. I think almost. Drug reactions, cardiovascular drug reaction, and casual agents. Coronary vasospasm, cocaine, amphetamines, sumatriptan, ergot-alkaloids. And then you have cutaneous flushing because of vancomycin, adenosine, niacin, calcium, channel blockers, echinocandins, nitrates, flush from vancin, vancomycin infusion reaction, formerly called Redman syndrome, rate-dependent infusion reaction to vancomycin, causing widespread pruritic erythema due to histamine release, managed with diphenhydramine, slower infusion rate. Then you have dilated cardiomyopathy, alcohol anthracycline, for example, doxorubicin, donrubicin. These create free radicals, so that's what it's known for. And for dilated cardiomyopathy, there are not that many drugs that do this, but so out of them, at least remember these two. Okay, the way I remember it is Don is, a person who beats up someone, so it beats up the heart and makes him dilate. And then there's Ruby in it, and Doxo, right? So Ruby is like a little gem. From the gem, I remember it creates free radicals. That's I remember that one. It prevents with dexamethasone and trastuzumab, and that's the third drug you should know about. So these two plus this one is the one that causes dilated cardiomyopathy. The other ones you can remember it, but definitely remember the three I just talked about. Torside the pointers or points. It's the agents that prolong QT interval. Uh, so the you have antiarrhythmics for A, that's class 1A and 2, I mean 3. Then you have B for antibiotics, that's for example macrolides or fluoroquinolones. Then you have C for psychotics, antipsychotics, that's ziprasidone. Then you have depressants for antidepressants is TCAs. Emetics E, antiemetics are for example and ondansetron. And then F as in antifungal, fluconazole. Okay, so remember these as well. Drug reaction, endocrine reproductive, drug reaction, casual agents, notes, adrenocortical insufficiency, that's hypothalamus pituitary adrenal suppression, secondary to glucocorticoid withdrawal. Then you have diabetes insipidus from lithium. This is important to remember that lithium causes DI and also demyclocycline. Gynecomastia is caused by, importantly, ketoconazole, but also cimetidine. Also remember about spironolactone. Uh, yeah, these two are the main ones, ketoconazole and spironolactone. Then you have GnRH analogs, antagonists, androgen receptor inhibitors, and 5-alpha reductase inhibitors. Hot flashes, SERMs, for example, tamoxifen, clomifen, and raloxifene. Don't worry about memorizing these because you'll learn about them in their respective chapters. So that's why I'm just going through it. Then you have hyperglycemia, tacrolimus, protease inhibitors, niacin, uh, hydrochlorothiazide, glucocorticoids. The people need high glucose. Okay. Hyperprolactinemia, typical antipsychotics, for example, haloperidol, atypical antipsychotics, for example, risperidone, metoclopramide, methaldopa, reserpine, and then presents with hypogonadism, for example, infertility, amenorrhea, erectile dysfunction, and galactorrhea. Hyperthyroidism, imidurone, iodine, lithium, hypothyroidism, amiodarone, and lithium. I'm lethargic. Remember that about lithium, it can cause hyper or hypothyroidism or DI. Then you have CIAD or inappropriate secretion of ADH. Carbamazepine, cyclophosphamide, SSRIs, selective serotonin receptor inhibitors. Drug reactions, gastrointestinal, drug reaction, casual agents and notes. Acute cholestatic hepatitis, jaundice, macrolides, for example, erythromycin. Diarrhea from all of these drugs. Like diarrhea can be for any reason, even ice cream. So that. Focal to massive hepatic necrosis, halothane, imidophyloids, death cap mushroom. Know about this one. It can cause hepatic necrosis, valproate, and acetaminophen. Then you have hepatitis from rifampin, isoniazid, pyrazinamide, statins, and fibrates. Pancreatitis, didenozin, glucocorticoids, alcohol, valproate, azathioprine, diuretes, for example, furosemide and hydrochlorothiazide. Pill-induced esophagitis. So potassium chloride, NSAIDs, bisphosphonates, ferrous sulfates, tetracyclines. Pills not beneficial for food type tubes. And then you have, hold on, usually occurs at anatomic sites of esophageal narrowing, for example, near the level of aortic arch. Causative effect minimized with upright posture and adequate water ingestion. Sorry. Pseudomembranous colitis, ampicillins, cephalosporins, clindamycin, fluoroquinolones, and PPIs. Antibiotics predisposed to superinfection by resistant C. difficile. We did that in micro anyways. Right? This was one of the major ones. You have drug reaction causing hematologic reactions, agranulocytosis, dapsone, clozapine, carbamazepine, propylthiouracil, methimazoline, colchicine, diclofenadine, and ganciclovir. And then you have aplastic anemia, carbamazepine, methimazole, NSAID, benzene, chloramphenicol, propylthiouracil, dichrome positive hemolytic anemia, penicillin, methaldopa, cephalosporin. Again, I'm only going fast because we'll read about these in the chapters. Drug reaction with eosinophilia and systemic symptoms, phenytoin, carbamazepine, minocycline, sulfa drugs, allopurinol, and vancomycin. Gray baby syndrome. This is an important one. Chloramphenicol. Hemolysis and G6PD, because we already did this one, so you should know about that one. Hemolysis and G6PD deficiency, isoniazid, sulfonamides, dapsone, primaquine, aspirin, ibuprofen, and nitrofurantoin. Megaloblastic anemia, hydroxyurea, phenytoin, methotrexate, sulfa drugs. Thrombocytopenia, indinavir, heparin, quinidine, ganciclovir, vancomycin, linezolid, and absceslimab. Then you have thrombotic complications, combined oral contraceptives, hormone replacement therapy, SERMs, and epotin alpha. That's for erythropoietin. Then you have the drug reaction, muscular, skin, and connective tissue ones. So drug-induced lupus, these are important ones. Methaldopa, minocycline, hydralazine, isoniazid, phenytoin, sulfa drugs, Intercept, and procainamide. Should know about this because we already done it. Fat redistribution, protease inhibitors, and glucocorticoids. This is an important side effect of glucocorticoids. Gingival hyperplasia, cyclosporin, we learned about that one. Then calcium channel blockers and phenytoin. Hyperuricemia, gout, pyrazinamide, thiazides, furosemide, niacin, and cyclosporin. Myopathy, statin, fibrates, niacin, colchicine, daptomycin, hydroxychloroquine, interferon alpha, penicillinamide, and glucocorticoids. You have osteoporosis because of glucocorticoids, medoxyprogesterone acetate, GnRH agonists, aromatase inhibitors, anticonvulsants, heparin, PPIs, photosensitivity, sulfonamides, amiodarone, tetracycline, and 5-FU. And then you have rash, this which is also known as Stevens-Johnson syndrome. Anti-epileptic drugs. If you don't know what this looks like, look it up. Actually, I'll do it for you. So it's a scary rash. It's not just like a little bump. It's like, scary face looking rash. Okay. So these are caused by anti-epileptic drugs, especially lamotrigine, allopurinol, sulfa drugs, and penicillin. Then you have teeth discoloration with tetracycline or tetracycline. Tendon cartilage damage or fluoroquinolones. Should know about these two. We already done it. Then you have neurologic symptoms, which is synchronism with quinidine and quinine. We'll do those when we come to that chapter. Parkinson-like, so quinidine and quinine, it can present with tinnitus, hearing, vision loss, psychosis, and cognitive impairment. Parkinson-like syndrome, antipsychotics, risperidone, metoclopramide, cognitive rigidity of arm, peripheral neuropathy, platinum agents, cisplatin, isoniazid, vincristine, paclitaxel, and phenytoin. Idiopathic intracranial hypertension, vitamin A growth hormones, and tetracycline. Seizures, isoniazid, bupropion, imipenem, celestin, uh, with celestin, the killing is lasting, something like that, right? Tramadol, and flurane. Then you have tardive dyskinesia, antipsychotics, metoclopramide, visual disturbances, topiramate, blurred vision, diplopia, halos, hydrochloroquine, decrease in visual activity, visual field, digoxin, yellow tinged vision. This is an important side effect of digoxin. Isoniazid is optic neuritis, ivabradine, luminous phenomena, vigabatrin is visual field defects. PDE5 inhibitors are your sildenafil, so that's blue tinged vision, and then ethambutol, that's color vision changes. Right, PDE5, we did that. Sildenafil, yeah. Okay, and then we have ethambutol, color vision change. Drug reaction, renal and genitourinary. Fanconi syndrome caused by cisplatin, ifosfamide, expired tetracyclines, tenofovir. Then you have hemorrhagic cystitis, cyclophosphamide, ifosfamide, and then you have interstitial nephritis, caused by diuretics, NSAIDs, penicillin, and cephalosporin, PPIs, rifampin, and sulfur. This is important. There are also drugs that cause acute kidney injury, so we'll do that in renal. Drug reactions, respiratory, drug cough, ACE inhibitors, remember, bradykinin can increase. Pulmonary fibrosis, methotrexate, nitrofurantoin, carmustine, bleomycin, sulfan. Okay, 10 minutes left. And amiodarone. You have drug reactions, multi-organ. Drug reactions are antimuscarinic, and the agents causing it is atropine, TCA, H1 blockers, antipsychotics. Disulfiram reactions, those are the kinds that give you hangover-like symptoms. So first generation sulfonylureas, procarbazine, certain cephalosporins, brisiofulmin, metronidazole. Then you have nephrotoxicity, ototoxicity, loop diuretics, cisplatin, aminoglycosides, amphotericin, and vancomycin. Drugs affecting pupil size, so increasing mydriasis are anticholinergics, for example, atropine, TCA, tropicanamide, scopolamide, antihistamines, indirect sympathomimetics, for example, amphetamines, cocaine, LSD, mipyridine, and direct sympathomimetics. So I already went over this. So yeah, these are the dilator muscles. They get contracted to cause mydriasis, right? And A1 receptor mediated. Then you have pupil size meiosis. This is sympatholytics, for example, alpha 2 agonists, opioids except mipyridine, and parasympathomimetics. So, for example, pilocarpine and organophosphates. Right? You have sphincter muscle contractions, M3 receptor mediated. Okay. Then you have cytochrome P450 interactions selected. This is one of the most important parts of this chapter, because You won't find this in other chapters, so you should like screenshot this or something and learn this. Like memorize which drug is are the inducers, substrate. These are the substrates. So these are the drugs that will get uh, either induced by these or inhibited because of these. Because these require cytochrome P450 to function properly. Okay, so quickly, inducers: St. John wort, phenytoin, phenobarbital, modafinil, nebupromine, rifampin, grisulfulvin, carbamazepine, and chronic alcohol overuse. So St. John's funny mom never refuses greasy carbs and chronic alcohol. And then you have inhibitors, which is sick faces come when I am really drinking grapefruit juice. Sodium valproate, isoniazid, cimetidine, ketoconazole, fluconazole, acute alcohol overuse, chloramphenicol. Uh, you have erythromycin, clarithromycin, sulfonamides, ciprofloxacin, omeprazole, amiodarone, ritonavir, and grapefruit juice. Grapefruit juice is an inhibitor. That's why they tell you not to drink or take medicine with grapefruit juice, because this. So theophylline, OCPs, and antiepileptics and warfarin are the substrates. Okay. Sulfa drugs, sulfonamides, antibiotics, sulfalazine, procinamide, uh, benacid, probenacid, furosemide, acetazolamide, celecoxib, thiazides, and sulfonylureas. Patients with sulfur allergies may develop fever, urinary tract infection, Stevens-Johnson syndrome, hemolytic anemia, thrombocytopenia, agranulocytosis, acute interstitial nephritis, and urticaria or hives, and photosensitivity. For these, if you are having a hard time remembering all of it, remember just one side, and then all the drugs that are not in that side, you can just assume that it's on the other side. Okay. Uh, Remember the azoles are inhibitors. Okay. They'll test you on that. They'll give you theophylline as given with other drugs as well. So why are they having adverse effect for theophylline, whatever it is? And then you can tell them it's because there's more theophylline in serum than there should be, because it's not being metabolized by cytochrome P450 because it's being inhibited by one of these. Okay. And then we have pharmacology miscellaneous, drug names and their categories, which is not so fun to read about, but we'll do it when the chapter comes, so there's no need to go over it by me. You can just do it on your own. And we're done for the day.